So I'm logging in now. So once you're logged in, you have this CMS video course here. If you click on the CMS video course, you'll be directed to the course. If you're fresh to this, you have to click on this buy this course form so that you can enroll into this course. You have options of 6 months, 12 months, 18 months and 2 years of validity with the flexible prices. And what is the course, what are the contents of the course, a little bit of sample videos about CMS exam, everything is given in the overview column. Come back to this main page and click the curriculum. So here is the curriculum where I have included what are the course latest updates, what is the notifications, what are the sample videos and notes. You can find it here in lecture 1.3. So we have also included a recent 2025 UPSC CMS solved paper with answers and discussion video. After that, each subject like general medicine, you have cardiology, pulmonology, and within that, what are all the important topics as per the syllabus. Like whatever syllabus is given, according to that, we have segregated subtopics, previous year topics, and recorded videos. The timeline of videos is mentioned there. And within the course, if you open that within the video, you will also find here you will find the video and also the PYQs from that topic particularly segregated, and you can also download the notes of this particular thing within the video section itself. See, this is the notes which we are giving, the notes handout. So the discussion video along with the notes will be given so that you don't have to make a separate notes. You can download this, you can take a printout of this note. So each subject, each subtopic, each video has separate notes and separate PYQs with explanation attached to it. So likewise, when you focus on this column, these are all the lessons that we have, these are all the videos of different subjects, these are all the topics of different subjects, and at the end we are also giving you the mock test. Okay, mock test paper 1, question paper 1. So here this exam is not online mock test, we are giving or simulating the exam, exact final exam, wherein you have to download your question paper. If you click here, you can download the question paper, you can download the OMR sheet, you can download the model answers also. So now you have to download the OMR sheet and then you have to solve. So this is the question paper you have. I'm just showing the sample. You can even download model the OMR sheet here. You have to take a printout of them and you can practice at home. So you will also have along with the OMR sheet that we are providing, you will also have the solution key, the answer key attached to it. Right? So likewise for each of this exam, we are also giving model answers. Okay, after completing, you can come back and read the model answers. So likewise, we have 4 mock tests in this, all the videos, all the notes. So I think it goes without saying, you will be having kind of let's say the best UPSC CMS course in the most exam specific, syllabus specific, PYQ centric fashion. It would be a single and comprehensive course. Okay, on top of that, if you have any questions or doubts, help you with CMS related questions or CMS related guidance or mentorship, whatever it is, feel free to call me. And all the best for UPSC CMS 2026 exam. Welcome everyone, Dr. Naveen here from UPSC MEDICO. So we will be discussing questions from general medicine subject of 2025 UPSC CMS examination paper. So the solution will be brief. The detailed solutions are part of our UPSC CMS video course, which is live in the website. Now let's get on to the question number 1 from general medicine. Just as an introduction, general medicine of UPSC CMS has 96 questions. The remaining 24 questions in paper 1 are from pediatrics, including together they amount to 120 questions. Now, among 96 questions, the question number 1 is, which one of the following is correct regarding arginine, vasopressin, antagonist, tolvaptan? So, to begin with the discussion about tolvaptans, these tolvaptans are actually the vaptans class. They belong to V2 receptor antagonists. Okay, so V2 receptor antagonists are classified into oral and IV, that is parenteral drugs. Now these oral drugs which I am talking about, like tolvaptan is one drug, lixivaptan, and we have satavaptan, and we have mozavaptan, which is latest drug. So these are the vaptan drugs or vaptans which are actually selective. These are selective V2 receptor antagonists. They specifically target V2 receptor which exclusively works against management of hyponatremia. Because for treatment of hyponatremia, we use these Vaptons. Vaptons are V2 receptor antagonists. So what is this V2 receptor? Arginine vasopressin, which is synthesized by posterior pituitary. Posterior pituitary synthesizes two hormones. We have oxytocin and we have vasopressin, otherwise known as arginine vasopressin, which is an antidiuretic hormone. Right now, it acts on two kinds of receptors, V1 receptors and V2 receptors. When it acts on V2 receptors, it selectively acts on the kidney, which leads to water retention. Because it's an antidiuretic hormone, this leads to water retention. Whereas V1 receptors are present on the blood vessels. So that's the reason there is vasoconstriction. Okay, mainly vasoconstriction happens if it acts on V1 receptor. Now you know briefly about what are this vasopressin receptors, that is V1 and V2. Coming back to Vaptons, Vaptons are antagonists. That means they have a mechanism of diuresis. Where is diuresis as treatment is required? It is required for the treatment of hyponatremia. Now within hyponatremia, we have three types of hyponatremia. You have euvolemic, you have are hypervolemic, or you have hypovolemic. Hypovolemic. See, for UPSC CMS, electrolyte imbalances or electrolyte disturbance questions are very common questions. Okay, so what are we discussing now? We are trying to understand the concept of Vaptons. Vaptons are V2 receptor antagonists. When we talk about Vaptons, we have oral Vaptons and parenteral Vaptons. Let me also list the parenteral Vapton because in future they might ask about this, that is conivaptan. This conivaptan is a parenteral Vapton which is given in IV, whereas all other Vaptons like tolvaptan, lixivaptan, SATA and moza, these are selective V2 receptor antagonists. They mainly act on the kidney. They're mainly used for treatment of hyponatremia and they're oral agents. Now coming back to what is the indication of these drugs or where are these drugs used? These drugs are used for management of hyponatremia. So what type of hyponatremia they're mainly used? They're mainly used for either euvolemic or hypovolemic. These drugs, AVP antagonists, that is Vaptons, they are effective in euvolemic, hypervolemic. The important condition that you need to know from exam point of view is syndrome of inappropriate antidiuretic hormone secretion, SIADH. Okay, which is a euvolemic. It is very important indication. Whereas these are contraindicated. This point is very important. These are contraindicated in hypovolemic hyponatremia. So this point is important because the first option in this question, as you see, tolvaptan is an oral drug. Okay, it antagonizes the V1 receptor. Okay, selectively. Okay, it is a not sorry. This statement is wrong because it antagonizes V2 receptor. Okay, so this statement is wrong. Now next question is, it is useful in hypo? No, it is either useful in U or hypervolemic. Okay, and next thing is, when these Vaptans are used, they shouldn't be used as a chronic therapy because they have a side effect of liver toxicity. You can't use them for more than a month. More than or equal to that means 1 month. Cannot be used beyond that. So it should be used for at least 1 year is wrong. Any chronic Vaptan therapy is not advisable because of the liver toxicity. So the correct answer for this question is Vaptans are oral drugs. Why Vaptans are contraindicated in hypovolemic? Why Vaptans are contraindicated in hypovolemic hyponatremia? Because when Vaptans are given in hypovolemic hyponatremia, it causes worsening of volume depletion. Already there is kind of dehydration. On top of that, there is worsening of the volume depletion. Already hypovolemia is there. It causes, because of the diuresis, there is more volume depletion in these cases. So this leads to shock and renal failure. So first thing, chronic Vaptan therapy is not indicated because it causes liver toxicity. Vaptan therapy is not indicated in hypovolemic hyponatremia because it causes shock and renal failure. Okay, so with the help of this question, we were able to cover the complete concept of Vaptans. What are the different receptors that we have? Now, question number 2 from general medicine, that is, what is this syndromes that you see in the options? Alport, Bartter, Fanconi, and Gitelman. Now, question is, you have to diagnose what type of syndrome you see. Which one of the following condition is caused by mutations in the gene that encodes sodium potassium 2 chloride cotransporter? What is that? Sodium potassium chloride cotransporter 2. And what is the presentation? There is sodium wasting, there is hypokalemia, hypomagnesemia, and hypercalciuria. Okay, so when I look at this question, what comes into my mind is I am looking at an important concept for NEET PG or INACET or CMS exam, that is the difference between Bartter syndrome versus Gitelman syndrome, because I had seen so many questions being asked in these two topics. Okay, so many questions have been asked. One dictum that I used to remember is loop diuretics loses calcium, okay, whereas thiazides retain calcium. That means when we use loop diuretics, this causes hypercalciuria. That means more amount of calcium is lost in the urine. When thiazides retain calcium, okay, it causes hypocalciuria or it causes hypercalcemia. Okay, when more amount of urine contains calcium, this kind of leads to formation of renal stones. And now, where does loop diuretics act? Where does thiazides act? Okay, you need to know that loop diuretics, they act in the loop here, okay, in Na plus K plus 2Cl minus. So this is the area, sodium potassium 2 chloride transporter. So this is the area where loop diuretics act, and if this channel gets mutated, this leads to Bartter syndrome. So loop diuretic has a major side effect of hypokalemia. That's the reason we have to give potassium sparing diuretics whenever we give so much of loop diuretics. So this explains sodium wastage, this explains hypokalemia, this explains hypercalciuria. As if this sodium potassium transporter is getting mutated, the picture is similar to excess loop diuretics in the body. The picture is similar to excess loop diuretics in the body, and this condition is Bartter syndrome. Exactly opposite, there is a condition known as thiazides, which retain calcium, hypercalcemia, and you know where thiazides act? Thiazides act in the distal converter tubule sodium chloride channel, so NaCl channel. Okay, here it gets mutated, and this leads to hypercalcemia. Yes, there will be hypokalemia, there will be sodium boosting, and this condition is known as Gitelman syndrome. Okay, Gitelman syndrome. So based on this differentiation, I had seen so many questions coming in the MCQ based exam. The same thing is substantiated here. In the thick ascending limb of loop of Henle, if there is mutation in sodium potassium 2 chloride channel, it is Bartter syndrome. If there is sodium chloride channel in the distal converter tubule, if it gets affected, then it is a Gitelman syndrome. There is also epithelial sodium channel defect which causes Liddle syndrome. I'm not covering it here. Our main focus is mainly to be able to differentiate between Bartter and Gitelman. Now we have another options too here. So the answer for this question is Bartter syndrome, because you see sodium wasting and hypercalciuria, hypokalemia. If the same thing presents with sodium chloride channel mutation with hypercalcemia, then it will have been Gentleman syndrome. Now coming back to Alport syndrome is a rare genetic disease. Here also you will see chronic kidney damage or injury, but this is because of the mutations in collagen genes, collagen A genes, that is collagen 4A3 or 4A4 or 4A5. These gene mutations which affect type 4 collagen. This is Alport syndrome. The mutations for Alport syndrome. And now we have another option, that is what is Fanconi syndrome. Fanconi syndrome is also a proximal. It is global dysfunction of proximal tubular function. Proximal tubular function. These are the other four options that you see in this particular question, right? Now let's go down to the next question. Now there is a 52-year-old male who is presenting with uncontrolled diabetes. Which of the following tests will help in early detection of nephropathy? See, one of the leading cause of chronic kidney disease, okay, chronic kidney disease or renal failure or renal transplantation is diabetic nephropathy. Now for that reason we have to screen for diabetics. In any diabetics we have to screen for diabetic nephropathy, that is kidney getting affected. So what is a sensitive marker? Usually if you see any diabetic in your clinic, advise urine albumin test, okay. If there is proteinuria, then you have to do definitive test to confirm, okay. So if there is elevated albumin, that is proteinuria, this proteinuria is not nephrotic range. Actually this is micro range, that is they call it as micro albuminuria. Exact term or perfect term is micro levels of albumin, okay, are passed in the urine. Micro albuminuria, okay. So micro levels, it is passed in the micro levels, right? So correct answer for this particular question is urine albumin, the first thing that we see. Later on, if there is severe damage, chronic kidney disease, then serum creatinine levels get affected, blood urea levels get affected. If you saw ultrasound, you will see shrunken kidneys, right? So these are the tests which come later. But first thing that we do is, the best thing that we do is microalbuminuria. The specific is again any kidney dysfunction. The specific test what we do is estimation of GFR, that is glomerular filtration rate. Now question number 4, autosomal dominant mutations in which one of the following genes may cause. What are the conditions they give? One is FSGS, that is glomerulonephritis, abnormal genitalia, Wilms tumor, and mental retardation. Now this is little tricky because they're asking you to identify a special syndrome. That is, first they have given W. Now next they have given genitourinary abnormalities, G. They have given mental retardation, R. Now we are left with A, okay. This A is aniridia, Wilms tumor, genitourinary. So genital, you will see abnormalities, abnormal genitalia. Urinary, you will see focal segmental glomerulosclerosis, that is glomerulonephritis. Or yes, mental retardation is always there. So this is Vagar syndrome. Vagar syndrome results from deletion on chromosome 11. Remember, chromosome 11 deletion leads to Vagar syndrome, and it is because of WT1 gene mutation, and this is inherited in a autosomal dominant fashion. This is inherited in an autosomal dominant fashion, WT1 gene. So the correct answer is WT1. So when we talk about FSGS, S, that is focal segmental glomerulosclerosis. You know, glomerulonephritis has minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, membranoproliferative one, and rapidly proliferating glomerulonephritis. These are all the spectrum of glomerulonephritis. Among them, we have a specific condition known as FSGS, which is most common in adults. Minimal change disease is most common in children. Now, when we talk about FSGS, there are hereditary causes of nephrotic syndrome, because the picture here is nephrotic syndrome. In case of focal segmental glomerulosclerosis, hereditary nephrotic syndrome, that is hereditary causes are there. So these hereditary causes are mainly autosomal dominant in nature. So autosomal dominant inheritance, and there are three causes which were identified in which you will see autosomal dominant hereditary nephrotic syndrome because of the gene defects. So what are the condition and what are the gene defects that are expected? Let's see. Now the condition is the first thing which we're talking about, that is Vagar syndrome. Vagar syndrome is mental retardation, Wilms tumor, abnormal genitalia. This is because of a gene defect, that is WT1. Next, what we have is nail patella syndrome. Nail patella syndrome, and in nail patella syndrome is because of the genetic defect, that is LMX1B. And next, what we have, the third one is Charcot. You might have heard about it. Charcot Marie Tooth. This is Charcot Marie Tooth disease, and this is because of mutation in INF2. Now you see, there are three conditions which are given. INF2, which is because of the Charcot Marie Tooth disease, LMX1B, which is because of, again, second condition, the nail patella syndrome. These three genetic mutations, they lead to autosomal dominant nephrotic syndrome because of focal segmental glomerulosclerosis. But among them, because they have given abnormal genitalia, Wilms tumor, and mental retardation, I am referring to Vagar. Vagar syndrome is because of W1. What is this ApoL1? Just to rule out other options, ApoL1 gene also leads to increased risk of chronic disease. It is also inherited in an autosomal dominant manner, but that is in a polymorphic fashion. It does not have any specific symptoms or syndromes like this, like abnormal genitalia, Wilms tumor. So this is also ruled out. But all these four genes are implicated in the autosomal dominant inheritance of the hereditary nephrotic syndrome, and the presentation is focal segmental glomerulosclerosis. Right? Now, little difficult question. This is easy. This is repeat. Like it's been repeated 2 to 3 times by now. You just have to know the staging of chronic disease, chronic kidney disease, and in the latest books, the staging system that we follow is KIDGO staging system. Okay, kidney disease improving global outcome. Kidney disease improving global outcome. KIDGO classification of CKD based on the GFR. It has been divided into, we have G1, G2, G3, G4, G5. I'm referring to the stages. Stage 1, stage 2, stage 3, stage 4, stage 5. You know, stage 3 is again divided into stage 3A and stage 3B. Now, normal value, somewhere around, we get around 120 to 90, right? This is the normal value. If it is falling, if it is above the 90, if it is above 90, so are equal to 90, I'm talking about 90 ml per minute per body surface area, that is 1.73 meter square is the standard that we take. If the value is about that, we are talking about normal GFR or high GFR. If GFR decreases to between 60 to 89, then we have second stage, that is mildly decreased GFR. If GFR is falling in between 45 to 59, 30 to 44, then we are referring to G3A, 3B. So both of them, what are we trying to know? One is mild to moderate, the other is moderate to severely decreased GFR. If it is very severely decreased, that means if it is between 15 to 29, then it is severely decreased. If it is less than 15, then I am referring to complete kidney failure. And it is severely decreased. severely decreased category is stage 4. Now, severely decreased category and G5 are the areas or zones wherein we try to go for renal replacement therapy, either via hemodialysis or we either go via peritoneal dialysis or we go for transplantation. So these are the things that we do when we come across very severely decreased or kidney failure, that is fourth stage and fifth stage. So within KidGo classification, in future they might ask you, because kidney failure is early detected by albuminuria, so there is staging for albuminuria as well, A1, A2 and A3, because consistently questions are coming in this zone. Maybe next year they might ask questions in this zone as well. Albumin levels in urine, if they are normal to mildly increased, that is, values are between 30 milligram per gram to 3 milligram per millimole. So whatever is the value, you can take either 30 milligram per gram or 3 mil. Let's only go for milligram per gram to avoid confusion. Okay, the exact values I have given in the description part in the course. But now what you need to remember is, based on the albumin values also, there is a classification system in KidGo. Okay, that is kidney disease improving global outcome. A1 is normal to mildly increased levels, that is less than 30 milligram per gram. Moderately increased levels, that means I'm talking about values in between 30 to 300 milligram per gram of albumin in the urine. Whereas severely increased albumin, that means I'm talking about more than 300 milligram per gram. So this is KidGo classification. Now coming back to the question, kidney damage and GFR value between 15 to 29. So what is 15 to 29? This one is 15 to 29. I am referring to stage 4, that is severe condition here. Very simple question to answer. Now the next question is, again we are referring to general medicine part of UPSC CMS 2025 solution discussion or model answer discussion. Now we are discussing more of questions from nephrology, and the reference for more of this nephrology questions, like almost 80%, is taken from Harrison. There are some topics for which we couldn't find answers in Davidson. Yes, 20% of the table part of questions are taken from Davidson, but the conceptual questions are taken from Harrison. Mostly nephrology, I think they are more focused on asking questions from Harrison, I believe. So all these questions which we have started discussing, Vaptons which act on kidneys, and the remaining questions which we have already discussed, like Bartter-Gitelman syndrome, diabetic nephropathy, Wager syndrome, that is genetic mutations which leads to glomerulonephritis, chronic kidney disease staging. All these are important questions. We are left with almost 3 more questions from nephrology. So the next question from nephrology, as you can see, is, which one of the following hereditary tubulointerstitial kidney disease has autosomal recessive mode of inheritance? Autosomal recessive mode of inheritance. Little tough question, but there is a direct table, straightforward table given in Davidson book. Right. So there are some conditions that they are called as hereditary tubulointerstitial kidney diseases. That means these are inherited in a hereditary fashion. So they can be inherited either in autosomal dominant fashion or autosomal recessive fashion, and they affect both tubules of the kidney and interstitium of the kidney. And those conditions which are inherited in autosomal dominant manner are medullary cystic kidney disease. We have type 1 and type 2. Both are inherited in an autosomal dominant fashion. Along with that, there is a condition known as juvenile hyperuricemic nephropathy. Remember this condition. Even this condition is also inherited in an autosomal dominant fashion. So what are the genes? The genes for medullary cystic kidney disease type 1, I am writing them in blue color. The gene for type 1 is MUC1 gene. The gene for type 2 is UMOD. Maybe next time they'll ask you what is the gene which is involved. Whereas the gene for juvenile hyperuricemic nephropathies, there are two kinds of genes which are implicated. One is HNF1 beta genetic mutation, or REN, which codes for renin. Both are implicated in causing juvenile hyperuricemic nephropathy. Now, autosomal recessive is our topic of interest because in the exam they have asked which one of the following condition is autosomal recessive mode of inheritance. So the answer is nephronophthisis. Nephronophthisis. So this nephronophthisis is a condition. Okay, it is a common cause of pediatric end-stage renal disease. Okay, and it has kidney disease because of involvement of NPHP genes, and this is inherited in an autosomal recessive fashion, and it is part of an important syndrome, that is Bardet Biedl syndrome. It is part of an important syndrome, Bardet Biedl. I'm talking about nephronophthisis, which is one of the common cause of pediatric end-stage renal disease. Along with kidney problems, extrarenal manifestations like the child will have learning difficulties here. Okay, the child will have learning difficulties and child will have eye or limb problems here. So this is what is nephronophthisis, which is autosomal recessive in inheritance, and the gene which is mutated in this condition is NPHP gene. Right? Shall we move on to the next question? The next question is, which of the following findings in a patient are suggestive of acute nephritis? Acute nephritis. Acute. Look at this option. Reduced size of both kidneys. For the kidneys to shrink, you need chronic pathology. So definitely you can rule out this option. So if this option is ruled out, you're left with hematuria. Yes, any kidney inflammation can cause hematuria. Any kidney inflammation acutely can cause decreased renal output, and the kidneys swell during acute nephritis. So these three can be possible options. 1, 2, and 4. Right? 1, 2, and 4. Now, there are some major syndromes in nephrology and there are important clues to diagnosis. Like, for example, we are done with acute nephritis. Now, if you want to diagnose chronic renal failure or chronic kidney disease, so what are the things that you see? Yes, you will see azotemia, that is uremia, increased urine levels. Uremia leading to so many other manifestations like encephalopathy and all. And you'll also see osteodystrophy, that means kidney getting affected, calcium metabolism also gets affected, bone problems will be there. You'll also see casts in urine. The type of casts you see are broad casts. Broad casts are categories of chronic kidney disease. Apart from that, the one characteristic thing is shrunken kidneys. Shrunken bilateral kidneys. If both kidneys are shrunken, then it is a chronic kidney disease. So this is how you diagnose chronic kidney disease. Acute nephritis and chronic kidney disease. So based on that point, they have asked this particular question. Shall we move to the next question? Yes, we're still lingering in the nephrology part. A lot of questions have come. Almost 1, 2, 3, 4, 5, 6, 7, 8 questions have come from nephrology, and majority the reference I have taken from Harrison, straight lines from Harrison. There are 2 questions from Davidson. So why I'm stressing upon this part? Because you cannot stick to one book in this exam. Okay, when we prepare answers and when we check for the questions, right questions and right answer, I could see I had to refer to multiple books. Right, I'm making it easy for you. I'm preparing the same content in the notes that we provide and also the model answers that we provide, so that we give you exact and accurate answer for this question. So that is my intent. Now coming back to the next question, 35-year-old male presented with increased urine output. Increased urine output, what was the urine output? 4 liters per day. That means we are looking at a condition known as polyuria. So how do you approach a case of polyuria? If there is a case of polyuria, you need to know whether it is water diuresis versus solute diuresis. This is the major hurdle for you because there are 2 different causes. Now, when I say water diuresis, I am referring to diabetes insipidus, which can be central or which can be nephrogenic. Diabetes insipidus, you will see water losing, that is water diuresis. Water diuresis is seen. In the similar way, there is one more cause, that is polydipsia, which is psychogenic. Polydipsia is also seen in diabetes mellitus, but it is not psychogenic. Psychogenic. Whereas diabetes mellitus kind of diuresis is solute diuresis, because there is excess amount of glucose. There is some solute like glucose. There is some solute like when we give mannitol, or when we give urea, high protein feeding, or when we give diuretics, etc. That is more of solute diuresis. Now you need to be able to differentiate between water diuresis versus solute diuresis, because in general, if any urine output more than 3 liter per day is known as polyuria. But when you see a condition of polyuria, you should know whether it is water diuresis or solute diuresis, because differential diagnosis is there. For that reason, we test serum osmolarity. We test for serum osmolarity. Normal serum, normal people excrete approximately 600 to 800 milliosmoles of solute per day. If urine output is high, but urine has less osmolarity, that means urine is dilute, that is less than 250 milliosmoles per liter only. Solutes are low, that means it is water diuresis. Opposite true, urine volume is high, even urine osmolality is also high. That means this is more than 300 milliosmoles per liter. Then we are looking at solute diuresis. So now look at this question. There is polyuria and there is low urine osmolality. That means the possible conditions are psychogenic polydipsia, central diabetes insipidus, and nephrogenic. It is never solute diuresis, because in solute diuresis you will expect more than 300 milliosmoles per liter. So the correct answer here is 1, 3, and 4. So the correct answer for this particular question is question number 1. So this is the concept of how you approach a condition that is polyuria. Right? Questions are not easy in UPSC CMS. They are conceptual. They are not copy paste anymore. Okay, but references are always are taken from standard textbooks. It's an MBBS standard exam. Final MBBS students can easily crack it, because you read all these lines from standard textbooks, but you need someone to make them understand for you. Okay, so focus here. Now this is the concept of polyuria. How to differential diagnose polyuria based on the serum osmolality value. If it is low osmolality, I'm looking at water diuresis. If it is high osmolality, we are looking at solute diuresis. Right? Good. Now slowly we move on to the neurology part. In the neuro, we have many questions, we have approximately 10 plus questions, but scattered around, because each key, the paper that I am discussing is in the order of code C. Okay. So this question is a neurology question. Let's look at this. There is contralateral homonymous upper quadrantanopia. Upper quadrantanopia. So one quadrant or upper quadrant is getting affected. This lesion is known as pi on sky. If I say lower or inferior quadrantic hemianopia, then it is pi on floor. So pi on floor. So these kind of visual field defects, pi on sky and pi on floor, are because of cerebral cortical defects. That is, if there is a lesion in temporal lobe, remember temporal. If there is a lesion in tempo up, pi on sky, then you will see superior quadrantic hemianopia. If the lesion is in parietal lobe down, that is floor, you will see inferior quadrantic hemianopia. So the correct answer here is temporal lobe. Visual field defect lesions questions are very important. Optic nerve pathway and what happens if there is lesion at identical places is important. So I have covered this in the regular discussion of neurology, and I have also included the text for these in the model answers, solved model answers of our course. Okay, you have to learn this topic thoroughly. Each year, 1 or 2 questions you can expect from this. Not only in CMS, any PG based entrance examination, you can expect questions from here. Right, let's move on to the next question. Simple question, headache. There are almost 2 to 3 questions in UPSC CMS 2025 exam on the headache part. Now, this is migraine. Migraine comes with aura. So, if you have to learn migraine, the first thing that you need to know is what is this aura. Before, if any of you have a migraine, even mere discussion of migraine can trigger migraine. There are so many triggers for migraine. There are so many triggers for seizures. There are so many triggers for asthma. In medicine, there are trigger factors. And as a doctor, as a physician, you need to know the trigger factors. You need to educate the patient that whenever these trigger factors are seen, you have to be extra cautious or you have to avoid these trigger factors. Okay, education is an important part of general medicine. So one reason why I love general medicine, one reason why I did MD general medicine is the reason that you can be actually a teacher to your patient. You can educate him. You can avoid all these unfortunate circumstances. And if you're learning for CMS, your job role is a general practitioner, right? Like one component of your daily routine is health education, right? So you need to know this, and this point is well stressed upon in the CMS exam. So there will be a lot of questions based on the education part. And PSM is majorly built on that, and major weightage in UPSC CMS exam is given to PSM, almost 40 questions. You will not see 40 questions in NEET PG or INA-CET or anywhere else, right? So they need a primary healthcare physician, they need a preventive doctor rather than a curative doctor. And in the interview also, they'll test your preventive knowledge. You will be a policy maker, you will be a diplomat, you will be working in tandem with Ministry of Health and Family Welfare to design national health programs in future if you go to that extent. So that for that reason, always and always for this UPSC CMS exam, focus on the preventive aspects, right? So trigger factors, health education is important. So for migraine, aura is you need to know a little bit about aura. But actually, though aura is important, only 20% of the cases, only 20% of the patients experience aura in migraine. The remaining 80%, they don't have any aura. So that condition is known as common migraine. So common migraine, 80% of the patients with migraine, they do not have any aura. Whereas classical migraine, which is seen in 20% of the cases, it comes with aura. We call it as migraine with aura. Migraine with aura. So when this aura is present, aura means some neurological symptom. It is mainly, this aura, when it is present, it is mainly visual in nature. That means the patient will complain, fortification spectra. The patient will complain fortification spectra. So what is this fortification spectra? There are some shimmering of the light, silver zigzag lines across the visual field, or there can be scotomas. All this together, fortification spectra. So aura is most often visual. Common migraine is seen without aura. Classical migraine is seen with aura. Common migraine is seen in 80% of the cases. Classical migraine is seen in 20% of the cases. And you know what is migraine? Migraine is simple. Migraine is dilatation of extracranial blood vessels. So that's the reason we give vasoconstrictors in the treatment. We give triptans, not vaptans. Vaptans is for kidney. Triptans, sumatriptan, migranil tablet. That will cause constriction. So the correct answer is 1, 2, 3. All 3 statements regarding migraine are correct statements. Right? Chalo. Next question. A 50-year-old man presents with brief episodes of unilateral lancinating facial pain. This itself describes a condition known as trigeminal neuralgia, that too in the buccal distribution. Okay, famous actor Salman Khan used to suffer with this condition. There's a lot of talk about in the media about this condition. Very painful condition. There are a lot of triggers for this condition. Okay, so this lancinating pain means it is like electric shocks. Patient will have electric shocks in the distribution of the buccal area. Okay, even talking or even chewing, okay, the pain will get triggered. It is very severe, very brief, repetitive. Even touching of cold wind to the face can trigger it. Okay, and when there is pain, okay, when there is pain, it is so severe and intense, but it is very brief. It lasts less than few seconds. Very sharp pain, like electric shock, but less than few seconds. Right? So correct answer is trigeminal neuralgia. You know how migraine presents, and medication overuse headache is a chronic headache. It's not acute headache. Chronic headache. One closest confusion to students in the exam is what is this chronic paroxysmal hemicrania? Chronic paroxysmal hemicrania is a unilateral headache, one-sided headache. It is again very severe. It has autonomic features. Autonomic features. The patient with chronic paroxysmal, suddenly it comes, but it is chronic in nature. Hemicrania, that is half of the head there will be pain, and patient will have autonomic features like he may complain of ptosis, he may complain of tearing in the eyes, he may complain of conjunctival injection. Okay, red eyes are conjunctival injection at the time of headache, and unilateral nasal congestion. Unilateral nasal congestion. This is how. See, headache as a topic is very important in any MCQ based exam. The headache DD. Okay, we are done migraine. Now you know what is chronic paroxysmal hemicrania. You also know trigeminal neuralgia, what is the lancinating pain. And medication overuse headache is like a chronic headache which occurs because of repeated use of painkillers for headache. For some days they got addicted to taking painkiller. Later, taking painkiller itself will trigger the headache. Then that becomes medication overuse headache. Right? Chalo. Next question. Which of the following are trigger? I'm talking about trigger factors are important, right? There are so many trigger factors for seizures. If you're counseling any patient with epilepsy, okay, or if you're counseling any patient who is coming with a seizure for the first time, next time if there is repeated attacks, we call it as epilepsy. And patient, because of sleep deprivation, if patient is not taking anti-epileptic drugs, if patient is having any recreational drug misuses or physical exhaustion, all this can trigger seizures. Easiest question. Apart from that, even alcohol withdrawal can also trigger seizures. And apart from that, flickering lights of TV, you might have seen in Netflix and all, whenever there is strobe effect, they say strobe effect might trigger epilepsy in cases, right? Strobe effect, lighting effect. So they will give you a warning before displaying those shimmering lights or flickering lights in TV and computer screens. Okay, so these are the triggering factors for seizures. Even infections, any intercurrent infection or any metabolic disturbance can also trigger. Metabolic disturbances can also trigger seizures. And uncommon situations like loud noises, uncomfortable situations like loud noises, loud music, hard bath can also trigger seizures. We have to be very careful when any patient with seizures comes across these trigger factors. Now, next cardiology question. There are some neurology questions which are there. We'll come back to that in between. But which of the following heart sounds are best heard with the bell of a stethoscope? This is a little confusing because per se, uh, when we talk about cardiology topic or when we discussed cardiology, we had discussed elaboratively in the course about what are the different types of murmurs, what are the different types of heart sounds, S1, S2, S3, S4, and where they are heard, and what is dynamic auscultation. So I have discussed these topics in greater detail because you will see at least 2 to 3 questions or 3 questions in each year, and easy to crack questions, right? Very easy questions. But problem here is there are two parts of a stethoscope. There is bell, which we don't usually use. Always and always we use diaphragm only while hearing the sounds, right? But there are some sounds which are heard best with the bell of the stethoscope. Okay, the smaller size. If this is the diaphragm, if this is the bell of a stethoscope, this is how the stethoscope is, right? This side is diaphragm and this is the bell. So bell of the stethoscope is for low pitched sounds. So wherever you see any murmur which is low pitched, any sound, any heart sound like S3 and S4 heart sounds are low pitched. S1 and S2 are loud. That's why we only hear S2 and S3 with the help of a diaphragm. Whereas if you want to hear S3 and S4, we go for bell of a stethoscope. Here the question is simple. Which of the following heart sounds are best heard with bell of a stethoscope? That is third heart sound and fourth heart sound. Both are best heard with bell of a stethoscope. Right? Now, there is one more point that you need to remember with regard to, see, if you know what are the sounds which should be heard with bell of a stethoscope, all the remaining sounds are better heard with diaphragm. Diastolic murmurs are better heard, and within diastolic murmur, the mid diastolic murmur of mitral stenosis is better heard with the bell of a stethoscope. Very important. Mid diastolic murmur of mitral stenosis. Okay, and even tricuspid stenosis will also have mid diastolic murmur, right? Even that is heard well with the thing. And one more murmur commonly asked in the exam, that is Austin Flint murmur. Austin Flint murmur. Carey Coombs murmur was asked this year. We'll talk about that. Even Carey Coombs murmur. These are all low pitched murmurs. Carey Coombs murmur, Austin Flint murmur. They are heard best with the bell of a stethoscope. Okay, you have to place bell very lightly on the chest and you will be hearing Austin Flint, Carey Coombs, mid diastolic murmur of mitral stenosis, S3 and S4. All the remaining sounds are murmurs which you come across, S1, S2, opening snap, which is loud, systolic clicks, which are loud. All these are heard with the help of a diaphragm. So coming back to the question, opening snap and systolic click are heard better with the diaphragm. Third heart sound and mid diastolic murmur of mitral stenosis are best heard with the help of bell of a stethoscope. So the correct answer here is 3 and 4. So option 3 is correct answer. Right? Now, next, in cardiology, when you see any case of myocardial infarction, case of MI, recently admitted in the hospital, you are done necessary treatments. Later to that, there is risk of complications in this patient. Immediate complication, life-threatening complication, most of the time that we come across is arrhythmias. Patient might develop arrhythmias. One of the important complication which many of the times question have come is ventricular aneurysms. To prevent these ventricular aneurysms, after the attack we give ACE inhibitors, okay, ACE inhibitor therapy to decrease the chances of ventricular remodeling and to decrease the chances of development of ventricular aneurysms and to decrease the chances of ventricular rupture because of the ventricular aneurysms. In the case of MI, we give ACE inhibitors. So if at all it develops ventricular aneurysm as a consequence of a recent MI case, what are the clues, or how can you detect early? How can you early detect the chances of development of ventricular aneurysm in these cases? So that is the question here. So for that reason, first and foremost, you need to know that this ventricular aneurysm is seen in 10% of the patients who present with MI. Let's say there is a patient of MI admitted in the hospital. The chances of him getting affected with a ventricular aneurysm is only 10%. Okay, 10%. And patient will have on chest wall, there is a paradoxical impulse. When you examine the patient will present with a paradoxical impulse on the chest wall. And when you do an ECG, usually ST segment elevation is an indication of MI, but even after treatment, the ST segment elevation is persistent. So any persistence of ST segment elevation in a case of MI, you should have a doubt that, okay, the patient might be landing up into ventricular aneurysm. And when you do a chest X-ray, so you have inspection, you have in cardiac examination, it can be palpation or auscultation, you will see paradoxical impulse. In ECG, you will see persistent ST elevation, and in chest X-ray, when you do chest X-ray, and when you look at the cardiac architecture, or we call it as more precisely in radiology word, we call it as a cardiac silhouette. When you observe the cardiac silhouette, it is enlarged. So enlarged cardiac silhouette on chest X-ray, persistent ST elevations on ECG, and when you examine, there is a paradoxical impulse on the chest wall. All three things point to chances of development of ventricular aneurysms. Okay, so but actually these are the doubtful things. So when there is a doubt for diagnosis, we go for 2D echo. If 2D echo confirms ventricular aneurysms, okay, it is like the prognosis is poor. Sometimes we can go for surgical removal also, but it contains very high morbidity and mortality. But it is necessary. So the treatment is surgical removal of aneurysm. But this surgery carries very bad prognosis, very bad prognosis, right? That's it. So paradoxical impulse on chest wall, persistent ST elevation on ECG, unusual bulge from cardiac silhouette and chest X-ray are the three features which will help you in diagnosing ventricular aneurysm in a patient with recent MI. Pulsus paradoxus, no. Pulsus paradoxus can be active if there is a ventricular rupture which leads to cardiac tamponade. Now there is no cardiac tamponade. What is this pulsus paradoxus? It itself is a very important question in UPSC CMS exam. You need to know what is pulsus paradoxus. It is not about pulse. Okay, we think that it is about pulse. That is a paradox here. I'm not talking about pulse. I'm talking about systolic BP. Systolic BP, there is a pathological decrease, that is more than 10 mmHg decrease in during inspiration. Pathological decrease of SBP during inspiration is pulsus paradoxus. It is seen in cardiac tamponade. Apart from cardiac tamponade, what are the other conditions where you see? It is also a question, just to for the sake of revision. Pulsus paradoxus is seen in cardiac tamponade. It is seen in constrictive pericarditis. Inspiratory fall in BP is seen in this thing. It can be seen in SVC syndrome, that is superior vena cava syndrome. It is also seen in severe respiratory obstruction like asthma and COPD, very severe obstructive airway disease. Obstruction can also be because of croup. It is also seen in croup conditions, and very importantly, it can also be seen in tension pneumothorax. So these are the conditions where you see pulsus paradoxus. Okay, these are the conditions where you see pulsus paradoxus. Then, chalo. Let's move on to the next question. Which of the following statements is correct regards subcutaneous nodules? Subcutaneous nodules in rheumatic fever. Rheumatic fever, the diagnosis is Jones criteria, not to be confused with Duke's criteria. Duke's criteria is for infective endocarditis. In infective endocarditis, you will see Roth spots, Janeway lesions, Osler's nodes, etc. Whereas Jones criteria, you have major and you have minor criteria. In the major criteria, there are two important things, that is erythema marginatum and subcutaneous nodules. Apart from that, you have Sydenham's chorea. You have arthritis as a major condition, right? It's a major manifestation. So subcutaneous nodules are major criteria. They occur in 5 to 7% of the cases, and as you see in the image, these subcutaneous nodules on the skin, okay, they are firm, they're painless, they don't cause any pain, they're firm, they're painless, and they're very small. Small in the sense, what is the usual dimension? 0.5 to 2 centimeters in size, painless, and usually they're present on the extensor surface of bone and tendon. They're present on extensor surfaces. They're subcutaneous only, but mainly localized on bone and tendons, extreme. Right? So this is how they present. So here the question is, which of the following statement is correct about subcutaneous nodules? They are present over flexor aspect of forearm? No. They are present on extensor aspect. They are painful? No, they are painless. Osler's nodes are painful in infective endocarditis. The usual size is 3 to 5 centimeters. No, they are 0.5 to 2 centimeters. They typically appear more than 3 weeks after onset of other clinical manifestations. Yes, they're not seen immediately. You will see arthritis, you will see carditis. Okay, you will see carditis. You will see erythema marginatum. You will see Sydenham chorea. After that, after more than 3 weeks of other clinical manifestation, you will see these subcutaneous nodules coming up. Right? Because they have asked subcutaneous nodule question now, maybe in future they might ask a question on erythema marginatum. So let's look at erythema marginatum also. So this is erythema marginatum spotter. See, I'm showing you images, but images are like image-based questions are never asked in CMS, not to be confused. I'm showing you here because when you look at an image, it is easy for you to comprehend or understand what I'm trying to tell. Maybe many of you, if not now, in the future, you will be writing NEET PG entrance examination. I think this content should give you that insights as well, the spotter questions, because other NEET PG or INA-CET questions, they contain a lot of spotter based or image based questions, right? So for that reason, I'm also showing you some of the images while I teach. I do this even during our regular classes in the course. Now, erythema marginatum, because they asked a question on subcutaneous nodule, in future they might ask a question on what is this erythema marginatum. So this erythema marginatum occurs in less than 5% of the patients. Okay, they are red macules, as you can see. They start red macules and they fade in center. Fade in center. This description of lesions is important for an exam like CMS, because they are not showing you any spotter image. The description becomes even more important for you to remember, right? Hope you're getting my point. So red macules that fade in the center but remain red at edges are red, but in center it is fading, and they're present mainly on the trunk. So the organ where they're commonly present are trunk and the arm you're seeing, that is proximal extremities. The seen in proximal extremities, they're mainly seen in trunk and proximal extremities. They're never seen on face, not on face. They're seen in less than 5% of the cases, right? So this is erythema marginatum. Then subcutaneous nodules, erythema marginatum. Next question. Which of the following is correct with regard to Carey Coombs murmur? So murmurs are important from cardiology. And one thing is clear. This is soft murmur. And it is mid-diastolic murmurs. And mid-diastolic murmurs are better heard via bell of a stethoscope. Bell of a stethoscope. And this is seen in, it is mainly during an episode of acute rheumatic fever. You see acute rheumatic fever if there is mitral valvulitis. Acute rheumatic fever, you'll see this if there is a mitral valvulitis. Soft mid-diastolic bell of a stethoscope, mitral valvulitis. Right. So this is Carey Coombs murmur. So correct answer is option 2. Now we're discussing the cardiology. We're still in the auscultation part of cardiology. As I discussed, you do understand the importance of examination in cardiology. That's been favorite area where a lot of questions in general medicine of UPSC CMS comes from. Now, what is this opening snap? Opening snap is seen in mitral stenosis. Okay, it is best heard with bell of the stethoscope. No, it is loud sound, so it is best heard with diaphragm of a stethoscope. I think examiner is only centered on stethoscope in this exam. A lot of questions based on the bell and diaphragm and the murmurs part, right? So opening snap is a loud sound. It is heard best with diaphragm of a stethoscope. It is a high pitched sound, high pitched, and it's an early diastolic sound. It is not mid diastolic, it is early diastolic sound. That's why it is high pitched. Mid diastolic sounds are like very soft. In mitral stenosis, there is a mid diastolic murmur, which is heard best with a bell of a stethoscope. Now, apart from that, apart from the opening snap, okay, what is the opening snap? Is best heard at the second left intercostal space. No, we are looking at mitral area. What is the mitral area? Mitral area sounds are better heard at cardiac apex. Mitral area is cardiac apex, not second left intercostal space. Right? It is better heard at cardiac apex. So this is also wrong. This is also wrong. Now there are two more options left. Among them, you have to choose which is correct. Now option 2 is intensity of opening snap becomes louder when the wall is calcified. No, when the wall gets calcified walls will not make enough sound. Right? So when wall gets calcified, opening snap sound gets inaudible. This is the statement which is given in Davidson. If the mitral wall gets classified, the opening snap, which is heard early in the diastole, after the P2 component that you see here, it fades away because of the calcification of the wall. That's why you cannot hear it. So this is also wrong. Now opening snap moves closer to the second sound as the stenosis becomes more severe. Yes, the more closer the opening snap to the second heart sound, the more severe is the stenosis. Okay, so the correct option is answer 3. Right, the remaining options are wrong. This is tricky question. I think many of the students might not have answered it well because we don't learn this topic of arrhythmias at such a proficient level. So if one thing we know that adenosine is given, adenosine, IV adenosine is drug of choice for supraventricular tachycardia. At least we know that supraventricular tachycardia or ventricular tachycardia. But what response you can get when adenosine is given? Adenosine can terminate or adenosine can lead to complete recovery of the disease, or it can only cause transient AV block, or sometimes it has no effect. I'm talking about, if you talk about arrhythmia, what kind of response you can expect when we give IV adenosine? This is our topic of discussion. What are we discussing? We're discussing if there is an arrhythmia and if I give an IV adenosine induction, what response we can get? It is drug of choice for, as we all know, it is drug of choice for supraventricular tachycardia. So in supraventricular tachycardia, because of the AV block that it produces, it leads to termination of the attack. So the attack or arrhythmia gets terminated. Well and good, our work is done. But what happens in other conditions, like I talk about atrial flutter, I talk about atrial fibrillation, or I talk about atrial tachycardia. I'm talking about lesions which are related to atria. It only causes some transient AV block. Okay, not complete termination, it causes transient AV block. Okay, it causes transient AV block. What happens if there is ventricular tachycardia? This is adenosine only acts on the supraventricular area. It has no effect on ventricular tachycardia. So that's the reason when we give IV adenosine, okay, IV adenosine, if there is a supraventricular tachycardia like AV ventricular nodal reentrant tachycardia, there is termination. AF, there is only AV block, no termination. So that is not the drug of choice. Ventricular tachycardia also termination and complete. No effect. Atrial flutter also just AV block. So the correct answer, the correct response, or the correct matched thing is supraventricular tachycardia termination. Simple question. If they ask you supraventricular tachycardia, the drug of choice is IV adenosine. Instead of that, they have given a table and they have mentioned all the arrhythmias and the response, which is the correct response. The correct response in this question is option B. Correct? The correct response is option B. Now we're getting into the respiratory medicine or pulmonology questions. We're done with the major cardiology part. Now in the pulmonology, simple question, meter dose inhaler. See, one of the problem when we prescribe this MDI or with MDI with spacer in kids is that asthma is not under control. When a patient comes with asthma not under control, the first thing that as a general physician or a pulmonologist that you need to see is he using this spacer or MDI machine properly? Then only you increase the dosage or you shift to another drug, right? So for that reason, how it is used, what are the steps, what are the correct steps of using a metered dose inhaler has been an examiner favorite area, where even in INSET I had seen questions coming up from this. First of all, we have to remove the cap, then we have to shake the inhaler, ask the patient to breathe out first gently, and place the mouthpiece into the mouth, and head should go backwards to minimize oropharyngeal deposition. So ask him to slowly do a deep inspiration, depress the canister, and continue to inhale so that the aerosols go into the lungs. Then ask him to hold the breath for 10 seconds. So these are the things that we do. So incline the head backward to minimize oropharyngeal deposition, right? Remove the cap and shake the inhaler, right? Breathe out gently and place the mouthpiece into the mouth is also right. Hold the breath for 10 seconds is also right. Simultaneously begin a slow deep inspiration and depress the canister and continue to inhale. This is also right. So all the options are right, but they're asking you steps. Okay, so this is sequential order kind of question. My bad. Sequential order type of question. So first thing what we do? First thing, we remove the cap and shake the inhaler. So option 2, this is correct. Next thing what we do? We breathe out gently and place the mouthpiece into the mouth. Yes. Then we incline the head backward. Yes. Then we simultaneously begin a slow deep inspiration, depress the canister and continue to inhale, right? Then hold the breath for 10 seconds. So correct answer is option 3, sequential arrangement question. Okay, chal. Now under the stepwise approach to the management of bronchial asthma, very important. See now, bronchial asthma management is like it evolves. There are different organizations which publish guidelines, and the important part of guidelines are given by GINA organization. Okay, global organization for asthma control, GINA. According to them, in pediatric, for control, we can still give salbutamol. Salbutamol is a SABA, short-acting bronchodilator, right? Beta agonist. Whereas in adults, we don't give SABA now for the control. For acute relief, you can. Like if there is a status asthmaticus or acute severe breathlessness or acute attack of asthma, we do give SABA for control. But in long term, for chronic cases, seasonal asthma, you don't give Asthaline at all. Rather, we give low dose inhaled corticosteroids or we go for LABA. So that is the point here. Short acting beta 2 agonist is required only for symptomatic relief. But step 1, we give low dose inhaled corticosteroid. So what is the step 1 for the patient diagnosed with asthma? Low dose inhaled corticosteroid. Simple. I think you can't ask for any easier question than that. But if the patient is having moderately persistent disease, then you have to add LABA, that is formoterol or salmeterol. If severely persistent, increase the dosage of inhaled corticosteroid to high dose. If very persistent disease, also add oral corticosteroids. Right? So this is the thing. This is stepwise therapy, very important. Even in UPSC Civil Services examination for theory exam answer writing, they have asked this question for 10 marks recently. So step 1 is low dose inhaled corticosteroid. We don't give salbutamol. Now, a 62-year-old male chronic smoker diagnosed with COPD, on testing, there is values given, gold criteria. See, even in 2024, the question got repeated. Same, you need to know the gold criteria to be able to answer this question well. Right? So what is this gold criteria? Gold criteria is global initiative for chronic obstructive lung disease. Global initiative for chronic obstructive lung disease. It is for severity of airflow obstruction. You will identify severity of airflow. So severity of airflow can be identified with the help of spirometry findings. So what type of spirometry findings we are looking at? We are looking at two values. We all know, that is, first thing we will do force expiratory in the 1 minute FEV1 and force expiratory volume 1 divided by FVC. Now based on these values, we will decide the severity of airflow. Like let's say severity can be mild in nature, or it can be moderate in nature, or it can be severe in nature, severity, or it can be very severe. Now these are the four gold stages. Gold criteria. You have gold stages. So stage 1 is mild, stage 2 is moderate, stage 3 is severe, stage 4 is very severe. So what values are we looking at? Mild means when you do FEV1, it is more than 80% expected or predicted, more than 80% predicted. The same thing is in between 50% to 80%, or the same thing is in between 30% to 50%, or the same thing is less than 30% predicted. So then we have different stages. When I talk about ratio of FEV1 by FVC, okay, if it is less than 0.7, it is mild one. If it is less than 0.7 but FE1 is getting affected, it is 2. Yes, if it is less than 0.7. See, all these conditions, it is less than 0.7 only. So there's no confusion. So FEV1 by FEC, if it is less, indicates obstructive lung disease. And if FEV1 is in between predicted value 80 to 30, based on that, the gold stage is decided. Here, FEV1 ratio is 0.6, that is less than 0.7, fine. If FEV1 was 70% predicted, that means it is falling in the moderate range, that is moderate severity of COPD, that is stage 2 as per the question. The same question, instead of asking you an application based question, they have asked you the same question, just giving the categories in the last year. So that means any scoring system which is asked in this year, they can ask an application based question in the future. Okay, so you have to be very cautious with that. Now, very easy questions. Both cystic fibrosis is autosomal recessive, Wilson's disease is autosomal recessive. So I had seen like modes of inheritance. I have given you a full table, almost modes of inheritance for 80 diseases. There is a table in the course. Okay, in the model answers also go through it. These questions are very, 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 very important. So there's nothing much to discuss. These are all memory based. So cystic fibrosis is autosomal recessive. Wilson's disease is also autosomal recessive in nature. Now we're still in the respiratory medicine, okay, that is pulmonology. So there is a question on non-invasive positive pressure ventilation, okay, NI, non-invasive positive pressure ventilation. This is the condition, and this question is taken from Harrison again. Why I'm highlighting this, because sometimes we can't find answer to questions which were being asked in Davidson, and there is some usual argument between students and faculty about which book to prefer, right? Which book to read during your MBBS times. From medicine point, like if you ask me about PSM book, which book to read in UPSC CMS, I'll say Park is ideal, like gold standard. Similarly, for pediatrics, OP Guy. For OBG, Datta, right? It's a gold standard. Mm, for general surgery, there are some questions which has been asked from Manipal, and there's some questions which are coming from Bailey and Lowe, but majority from Bailey and Lowe. But general medicine, you have to mix both Harrison and Davidson. Application part, any conceptual part, any update part, Harrison. Tabular forms, memory forms, etc. are being asked from Davidson. So it's a mix and match. For each topic, when I'm teaching you, I'm referring both these books so that I cover both in the regular classes. Okay, so non-invasive positive pressure ventilation, they're asking you what are the contraindications. Contraindications where you use NABPV. The contraindications are if the patient is having cardiovascular instability, you can't use it. If the patient is having impaired mental status, it would be difficult. They will be removing this non-pressure, like they will remove with the hands. And if the patient is non-cooperative, that is inability to cooperate, and if the patient is having copious secretions, it's difficult to maintain, right? Copious secretion, aspiration, or if there is inability to clear secretions, in that case also we have this issue. And because non-invasive, that means we are not intubating the patient, we are just putting a face mask. If you put a face mask, if it is ill-fitting, that means mask is unable, you are unable to fit the mask. Fitting mask has some issues, you cannot fit the mask. So for that reason, the conditions are if there is any craniofacial abnormality, or if the patient is having extreme obesity, or if the patient is having burns on the face, in these cases you cannot fit a mask. Burns on the face or something, scars and all. So for that reason, these are the conditions where you see, or these are the contraindications where you cannot use non-invasive positive pressure ventilation. Right? So these are the contents. So coming back to the answer, yes, you cannot use in craniofacial abnormalities. Yes, if there is significant burns. If there is cardiovascular instability, yes. Respiratory failure with PaCO2, yeah, this is the indication, not contraindication. So what is an indication? If PaCO2 is more than 45 mmHg, you can use non-invasive positive pressure ventilation. Right? Yeah. Now next, which one of the following terms denotes the extensive sclerosis of the skin of the chest wall which restricts chest wall movement and is seen as a rare complication of systemic sclerosis? So systemic sclerosis or sclerodactyly, the skin is so uh, extensively sclerosed, it will not allow the chest to recoil or chest to expand. So this condition is known as hide-bound chest. So in systemic sclerosis or sclerodactyly kind of conditions where there is extensive fibrosis of the skin, sclerosis of the skin, it is cicatrizing in nature. Cicatrizing in nature that leads to restriction of the chest wall movement, and this condition is known as hide-bound chest. Flail chest is seen if there is a rib fractures. Okay, two or more rib fractures at the same time, it leads to paradoxical respiration. Paradoxical respiration. Pigeon chest is seen in rickets, case of rickets. Okay, barrel shaped chest is seen in case of obstructive pulmonary diseases. Okay, chest abnormalities and the differential diagnosis. For the correct answer for this systemic sclerosis condition is hide-bound chest. The diagram is seen here. Now, which one of the following childhood epileptic disorders often needs long-term treatment? See, among all the childhood, all these are childhood. Febrile seizures are not recurrent. Usually, after 5 years, you will not see them coming. So, usually, chronic therapy is not required. Benign neonatal seizures are also they do not require. Benign itself is they do not recur. But juvenile myoclonic epilepsy, the problem is they have a high recurrence part, and whenever we stop drugs, okay, it will recur. That's why it requires long-term anti-epileptic therapy. So the juvenile myoclonic epilepsy condition requires long-term anti-epileptic therapy. So I think almost 10 times in the last 10 years this question has come. What are the clinical features of Parkinson disease? Everything is a clinical feature, but it is not macro, it is micrography. I'm not discussing this because Parkinson's disease I did discuss in detail. Almost 15 to 20 symptoms we did cover in the regular part of the discussion. Okay, so correct answer is 1, 2, 3. It's not macrographia, it is micrographia. Right? Next. Clinical question. A 35-year-old female presents with easy fatigability. That means you're suspecting something called anemia. Investigations, oh, HB is very low. So anemia is confirmed. Now, red cell morphology is normocytic normochromic. And this condition, reticulocyte production index is 5.5. Now you need to know what are the implications of this reticulocyte production index. So reticulocyte production index, if it is more than 2, that means reticulocytes are being produced by the bone marrow. That means the bone marrow is responding to anemia. So there is no problem with marrow failure. If it is less than 2, that means the marrow is not responding. That means it is marrow failure, bone marrow failure, or for nuclear synthesis, nutrients are required. So it may be nutrient deficiency like vitamin B12 or folic acid. It can be megaloblastic anemia as well. Whereas if RPI is high, that means uh, this is iron or B12 or folic acid deficiency, etc. Right? But if RPI is more, that is more than 2, that means marrow is responding well. That means it can be because of blood loss, or it can be because of increased RBC destruction. That means I'm talking about hemolytic anemia. Hemolytic anemia. So here in this condition, RPI is high. This is ruled out. This is sideroblastic anemia is marrow failure. This is ruled out. So intravascular hemolysis is the correct answer for this particular question. Right? Now, a 46-year-old lady on vegan diet. Oh, strict vegans, vitamin B12 deficiency. I don't want to read extra, but again, vitamin B12 deficiency has tingling and numbness in lower limbs. Which one of the blood test is advised? Vitamin B12 deficiency, which can present with spinal or neurological problems. Okay, so here the condition that you see is dorsal column lesions. There is explanation, right? There is swaying of while walking through the narrow corridor. So that is ataxia, which is a manifestation that is seen. And tingling and numbness, that means peripheral neuropathy. They're all manifestations of vitamin B12 deficiency, which are commonly seen in vegan diet. Right? So we don't have to discuss much. It's clear and simple. It's clear and simple. Now, which one of the following causes low volume erythrocytosis? Erythrocytosis means erythrocytes are increasing in number, increased RBC count. RBC count is increasing. It can be absolute erythrocytosis or absolute. It can be absolute erythrocytosis or it can be relative erythrocytosis. Absolute means there is actual increase in RBT count. That means I am looking at a condition known as polycythemia rubra vera, or I am looking at myeloproliferative disorders, right? Or maybe in high altitude conditions, okay, in renal diseases, if there is tumors which increase synthesis of erythropoietin. In all those conditions, I'll say absolute erythrocytosis. But there is one condition that is relative erythrocytosis, otherwise known as low volume erythrocytosis. Here, the problem is not increase in RBC count. The problem is actually decrease in the volume of the blood. Like if you are giving diuretics, let's say, the blood volume is low. If the patient smokes a lot, or if there is any obesity, or if there is any alcohol excess leading to dehydration, and very importantly, we have a specific syndrome known as Gaze-Bock syndrome. Okay, so what I'm referring to, I'm talking about a specific syndrome known as GAIS, Gaze-Bock syndrome. So what is this Gaze-Bock syndrome? One thing is clear, that Gaze-Bock syndrome, you will see low volume erythrocytosis, which is relative. We can also call this as pseudo polycythemia. Pseudopolycythemia. It is not increased red cell mass, but you will still see elevated RBC count in these conditions. Okay, it is because of maybe this Gaze-Bock syndrome is maybe because of excess diuretic usage, excess smoking, or obesity, or alcoholic excess. So this condition is relative or low volume erythrocytosis, and they have asked it multiple times. It is not polycythemia rubra vera because it is absolute. It is not high altitude. It is absolute. Even excess testosterone therapy will lead to excess production of RBC. These are all absolute erythrocytosis. Gaze-Bock syndrome is relative erythrocytosis. Count is normal, but relatively there is pseudo or spurious values because of excessive usage of diuretic, smoking, obesity, or alcohol excess. So that is what is Gaze-Bock syndrome. Now, in a case of CML, I think it's a cakewalk question, right? CML means tyrosine kinase inhibitor. Tyrosine kinase means imatinib. In chronic phases, we give this imatinib and all. But in blast crisis or in relapse and cases, we go for second line or third generation tyrosine kinase inhibitors, or transplantation also is used, or chemotherapy drugs are also used. So first line therapy is tyrosine kinase inhibitors, and what do? They act on BCR, ABL, tyrosine kinase activity. Imatinib is one example. The other drugs are nilotinib and dasatinib. I think the easiest question you can ask for in general medicine is this. Next question is about management of idiopathic thrombocytopenic purpura, otherwise known as ITP. We all know that it's an autoimmune condition, right? There is production of autoantibodies against platelets. So when the platelets are getting killed, okay, the platelets are getting eaten away by the macrophages because of the antigen antibody reaction. There is decreased platelet count, in turn leading to increased risk of bleeding in these cases. Now, how do you manage this? Logic is simple. So, whenever you see a case of immune thrombocytopenic purpura, first see whether it's a stable case or there is complaints of spontaneous bleeding. If stable case and if platelets are more than 13 to 10 to the power of 9 per liter, then you don't have to worry. If the count falls below 13 to 10 to the power of 9 per liter, or if there is complaints of spontaneous bleeding, then only you need to treat this case. So each and every diagnosed case of ITP, we are not going to treat unless there is complaints of bleeding or platelet count is too low. Even in stable cases, if there is increased risk, like if there is chances of surgery, etc., then you do treatment. Otherwise, stable case, no treatment is required. If there is spontaneous bleeding, now we start with glucocorticoids, and here you need to know that the dosage of glucocorticoids is high dose. If you are using prednisolone, we give 1 mg per kg, but if you are using dexamethasone, we go up to 40 mg daily for 4 days. So high dose glucocorticoids therapy is given in these cases. Right? Glucocorticoids at higher dosages, they cause quicker immunosuppression so that the bleeding can be controlled. So in this, the bleeding can be controlled with the help of high dose glucocorticoids. This is, let's say, first line therapy. The first line therapy is high dose glucocorticoids in management of immune thrombocytopenic purpura. Now, even after giving high dose glucocorticoids, if the response is not seen or not, it's not good response, if the platelet count is not improving, for the sake of increasing platelet count, we can go for IV immunoglobulins. Okay, so if there is reduced or decreased response to high dose glucocorticoids, if there is severe hemostatic failure and bleeding is significant, spontaneous bleeding, but it is significant, very high, in those cases, we can go for IVIG. Even after giving IVIG and prednisolone, if there is potential life-threatening bleeding or if the bleeding is persisting, then we can even try platelet transfusions. Now, in cases of relapse, let's say you're treating ITP, responded well, you stopped glucocorticoids. After stopping glucocorticoids, the patient started relapsing. So immediately what we do for the first relapse, we reintroduce glucocorticoids. For the first relapse, we reintroduce glucocorticoids. For the second relapse, or 2 or more relapses, or if there is a refractory cases, we go for second line therapies. Do you know, even in nephrotic syndrome also, we start with some drugs. If the patient doesn't respond, later on we give steroid sparing immunosuppressants like rituximab, cyclosporin, mycophenolate maleate, tacrolimus. At the same time, we can even go for splenectomy as well. Response rate is good. So in refractory cases, apart from splenectomy and immunosuppressants, there are latest licensed drugs. So these licensed drugs are thrombopoietin receptor agonists like eltrombopag and romiplastin, and splenic tyrosine kinase inhibitor like fostafurmetinib. These are the 2 drugs that can be given, okay, second line therapy in refractory cases. Right? So this is how you're going to manage ITP, the whole flow chart. Now let's look at the case. Now the question, it is easy after understanding the management protocol. Let me read the statements. Try to say whether it is correct or not. So the question is about, you have to choose which of the following statements are correct. I think multiple completion type questions, these kind of questions are a dictum in UPSC CMS exam. The essence is you need to understand the topic in greater detail, right? So for that reason we do this. Now when I read this question, the first option is, in case of ITP, all patients with platelet count less than 100, actually it is 10 to the power of 9 per L, should receive high dose. No, it is actually spontaneous bleeding cases, or if the count is less than 30 into 10 to the power of 9, then only we go for high dose glucocorticoids. So if we give high dose glucocorticoids in patient with spontaneous bleeding, the dosage is 40 mg dexamethasone daily. Yes, it is correct. IV immunoglobulin can raise the platelet count. Yes, we give it in bleeding cases to increase the platelet count. Life threatening bleeding should be treated with platelets. This is also right. So statement 2, 3, 4 are correct in this case. So option 2 is correct answer, right? Now next question is, which of the following drugs can cause secondary weight gain? Secondary weight gain may be because of any disease, or secondary weight gain can be an endocrine disease, or secondary weight gain mainly is iatrogenic, that is drug induced ones. So now let's try to look at the causes of weight gain. Primary or genetic, okay, primary genetic, but secondary or there are causes like endocrine causes. So what kind of endocrine causes you expect? In diabetes mellitus, usually type 2 diabetes mellitus, insulin resistance, we all know insulin is adipogenic. Please remember this. Insulin is adipogenic. That means whenever there is excess insulin in the body, this leads to weight gain. That is the reason in type 2. Now, if there is a condition called insulinoma or initial part of diabetes mellitus type 2, because of the insulin resistance, you will see increase in weight. Vice versa in type 1 diabetes mellitus, because of insulin deficiency, young patients with diabetes type 1, they complain of weight loss, not weight gain. Okay, this is first endocrine factor. Apart from that, when we discuss about the causes of weight gain, notable mention is about thyroidism, that is hypothyroid. That means whenever the thyroid quantity is low, metabolism is less. Metabolism is less means cold intolerance, weight gain, hair loss, or etc. are the manifestations of hypothyroidism. Right? Hyperthyroidism, it is opposite, quite opposite. That means excess thyroxine, weight loss, diarrhea, etc. kind of things are seen. Now, apart from these two, you might have seen in Cushing's syndrome, because of the excess mineralocorticoids, glucocorticoids, this leads to weight gain, Cushingoid appearance, okay, puffy appearance. And any hypothalamic tumors or hypothalamic injury can also present with weight gain. Okay, these are all the endocrine secondary causes of the weight gain. Next time they might ask that as well. Now, the most important part of discussion here is the drug induced secondary causes. So what are the drugs which actually leads to weight gain? First and foremost, you might have seen many psychiatric patients suffering with weight gain because these atypical antipsychotics which are commonly used in the practice, they have the side effect of excess drugs. Similarly, as I said, psychiatric practice, we have amitriptyline, which is again a antidepressant. So patient coming with depression, you give antidepressants and it will lead to weight gain. And drugs like gabapentin and pregabalin, which are taken for chronic pain, chronic neuropathic pain, they also present with thing. And as I told you, insulin, common drug, okay. And concept of insulin is important here. So as said, insulin is adipogenic. That means it increases the lipid quantity, or it causes lipid formation. It is lipogenic or adipogenic. For that reason, if you take any IV, not IV usually, any parenteral, let me say, parenteral insulin, which is commonly given, you will see weight gain as a side effect. Along with that, if you come back to oral antidiabetics like metformin actually causes weight loss. Metformin decreases insulin resistance, causes weight loss. But there are some drugs which are known as insulin secretox, and the classical example of insulin secretox which we use is sulfonylureas, commonly used drugs, sulfonylureas, or thiazolidinediones. Sulfonylureas like glimepiride, gliclazide, all these drugs, including thiazolidinediones, they are insulin secretox. Anything which secretes insulin leads to weight gain. So let me put it this way: you have sulfonylureas and thiazolidinediones. Right? Yes, glucocorticoids, secondary Cushingoid disease or Cushingoid syndrome. Any glucocorticoid excess leads to Cushingoid kind of manifestations. You might have seen anti-epileptic drug sodium valproate has this side effect. Epileptics taking sodium valproate chronic therapy. And one notable thing is even beta blockers given in hypertensives, they carry risk of weight gain. Okay, so beta blockers like propranolol, insulin, And yes, these are the two drugs which can cause weight gain. Whereas Orlistat is actually used a drug, orexogen. It's a drug used for weight loss. It's a weight loss drug, Orlistat. Similarly, thyroxine excess leads to weight loss. So the correct answer here is option 1 and 2. Okay, 1 and 2. So option 4 is the correct answer. Okay, your take home is the secondary causes of weight gain, an expected question in the future. Now, under which of the following conditions the HPA axis suppression is likely to result in crisis due to adrenal insufficiency following withdrawal of glucocorticoids? So, during my internship, I went to this derma posting. In derma posting, the dermatology or cosmetology what we see in the modern era is quite different from the dermatology that is practiced in a government setup. They admit a lot of skin cases like psoriasis, squamodermal lesions, right? The chronic diseases. So there, they use pulse therapy. Pulse therapy. Pulse therapy means we give high dose corticosteroids for short span of time. For short span of time, then we take a break. Then we do one more cycle. We don't practice daily chronic therapy. So these daily chronic oral corticosteroids are given in uncontrolled asthmatic patients, which leads to weight gain. And also, in these chronic cases, if you suddenly stop steroids, this leads to withdrawal of the steroids, which lands up in adrenal crisis. So that's the reason whenever you want to stop chronic dosages also, like for example, for 10 days you are taking 10 mg, then for next 10 days take 5 mg, for next 10 days then reduce the dose to 2.5 mg, then like 1 mg, then stop it. So this is the way. Gradual tapering of the dosage of the corticosteroids is important to avoid the adrenal crisis. So whenever we give, if you want to give, only give a shorter duration time with a high dose. Don't give long duration, slow doses of glucocorticoids, because if patient suddenly stops, he'll land up into adrenal crisis. So here in this question, the examiner are asking, under which one of the following conditions the HPA axis suppression is likely to result in adrenal crisis? That means if glucocorticoids are given IV for 5 days, no. If glucocorticoids have been administered orally for 1 week, okay, you can give. If glucocorticoids have been prescribed repeatedly within the previous year, this is what happens with chronic asthmatics. If dose is less than equivalent to 5 mg, if low dose, it's fine. Okay, so this is the wrong option. Okay, that means this shouldn't be practiced. This has risk of leading to adrenal crisis. Right? So let's move on to the next question. Which of the following can be used for the management of severe hyperkalemia? In the same year, even the pediatrics has also the same question. Okay, peds. And ECG changes in hyperkalemia, treatment protocol of hyperkalemia. Like in last 15 years of my teaching experience, I had seen in one or the other exam, they will definitely ask a question on what are the ECG changes that are expected and what is the treatment. But peculiarity about UPSC CMS exam is the electrolyte imbalances part. They will ask a lot of questions on electrolyte imbalances, and mainly their focus is on hyperkalemia. Hyperkalemia is one area you would see a lot of questions coming up, and next comes hypernatremia. Okay, next comes hyper. These are the two areas, like excess potassium and reduced sodium. You will see like one or two questions like as a mandate in the UPSC CMS final exam. Right. So with this take home, let's move on to the question part. Which of the following can be used for the management of hyperkalemia? See, instead of like as I said, the management questions, it is better to kind of write down how it is treated. Then if you read the question, that would be easy rather than solving the question at first. Now, when you see any case of hyperkalemia, the problem is potassium level alteration leads to kind of the membrane permeability of the cardiac myocytes get affected. That is, action potential gets affected. It might trigger arrhythmias. When arrhythmias are triggered, it's life threatening condition, right? So whenever there is disturbance of the myocardial cell membrane, right? So for that reason, immediately what we do, stop offending agent. Like what is the reason behind excess potassium? Are we giving any potassium containing fluids or medications? So first we have to stop that. Step number one. Step number two, what we'll do is, our prime problem is arrhythmia. That means we have to find a way to stabilize, myocardial cell membrane. So what I'm trying to tell you is, when potassium levels are high, myocardial cell membrane potential or membrane's polarity changes. So we have to stabilize that to prevent cardiac arrhythmia. For that reason, we immediately use IV, okay, 10% calcium gluconate. IV 10% calcium gluconate is immediately used in these cases. Okay, if it is not available, you can even go for calcium chloride, but calcium gluconate is the preferred one. How to give also is important, because I had seen questions coming from important drugs. They're also asking the dosages 0.5 to 1 ml. Maybe even for interview also this might be important, because in interview they'll ask clinical questions, right? So IV 10% calcium gluconate 0.5 to 1 ml per kg. This should be given over 5 to 10 minutes. So when you're doing this, it should be done under the monitoring of ECG, or cardiac monitoring and ECG should be done when we are doing this. Whenever we give a calcium gluconate, there is risk of bradycardia. So if bradycardia is preferred, we immediately stop giving this drink. We're not treating the cause. It's like when there is fever, you're giving paracetamol. We're not giving antibiotic. Likewise, when there is hyperkalemia, you're only stopping the arrhythmias by stabilizing the myocardial cell membrane with the help of calcium gluconate. But to control the potassium levels, okay, potassium levels are high. So what can be done? We can either remove it from the body, elimination, or what we can do is, cell plus plasma are component, the values differ. In the plasma, cell has highest amount of potassium inside. Plasma has lowest amount, like it is in between 3.5 to 5.5 milliequivalents. If I can increase the intracellular potassium uptake, if I can enhance the cellular uptake of potassium, I should send potassium in the blood to the cell. So this can be done. Okay, cell uptake of potassium can be increased by, number one, this is the duty of insulin. If you give so much of, do you remember management of diabetic ketoacidosis? When we're treating a case of diabetic ketoacidosis, we will always check potassium levels. If potassium levels are low, we supplement, because insulin causes cellular uptake of potassium. Okay, similarly, the same work is also done by beta blockers. Okay, so not beta agonists. So what beta agonists we use? Do you know that SABA, short acting beta agonists like salbutamol, or long acting beta terbutaline, etc. So in asthmatic cases, if they use so much of these, they will also land up into hypokalemia, because there is cellular uptake. So these drugs like beta agonists like salbutamol or insulin, their mechanism of action is they increase cellular uptake of potassium. Somehow we are removing that. Instead of putting it into the cell, the same function can also be done by sodium bicarbonate. Sodium bicarbonate is also used in management of hyperkalemia, and when sodium bicarbonate is used, it will enhance the cellular uptake of potassium. Now from the body, if you want to eliminate, we have to use potassium binding resins. Somehow in the gut, we have to give something which binds to it and it removes it. Alright. So for that reason, for removal, for potassium binding resins, we have very important one, sodium polystyrene sulfonate, which can be either given oral or per rectal. Okay, this will remove most of the potassium body. Otherwise, do you remember when I'm teaching you Bartter syndrome and Gentleman syndrome? I told you the main side effect of these loop diuretics or thiazide diuretics, loop or thiazide diuretics, they lead to potassium depletion from the body. There is loss of potassium in the urine. That's why they cause hypokalemia. So for that reason, when we use them for longer duration, we also add potassium sparing diuretic like spironolactone. So if you know that concept, you can apply it here. That for elimination of potassium from the body, we can use loop and thiazide. So much of integration here. See, you know insulin, but it can be used here. You know beta agonist for asthma, but that can be used here. Sodium bicarbonate can be used. Sodium polystyrene sulfonate can be used, and loop diuretic can be used. So this is how you treat the case when potassium levels are too high. Now we have given calcium gluconate to stabilize. We are using all these other elements to decrease the potassium levels in the body. In spite of that, if hyperkalemia is there, then the next best method is, in very severe cases, we go for hemodialysis. So we can easily try hemodialysis for severe symptomatic hyperkalemia cases. Right? So this is the treatment part. Coming back to the question. Now, which of the following can be used for management of severe hyperkalemia? IV calcitonin? No. IV sodium bicarbonate? Yes. Oral sodium polystyrene sulfonate? Yes. Potassium binding? IV calcium gluconate? Yes. So these are the three options that can be used. 2, 3 and 4 is the right answer for this particular question. It is not calcitonin that is used. Okay. IV insulin is used, not calcitonin in these cases. Okay. So next question is, the hyperkalemia management part is done. As I said, electrolyte imbalances are important. One area I had seen a lot of questions coming up is the causes of hyponatremia. When we talk about hyponatremia, while we were discussing the first question of general medicine, that is Vaptons, V2 receptor antagonists, there I told you these Vaptons are used either for euvolemic hyponatremia, that means the standard example was syndrome of SIADH, or hypovolemic, the body has excess volume. Excess volume is body is unable to pump out the excess volume. That means excess volume or hypervolemic condition can be because of the congestive cardiac failure or because of the cirrhosis of the liver. All there you will see excess body fluid in the body. Even nephrotic syndrome also you will see hypervolemic hyponatremia. Right, even in CKD also there is failure. So body volume is high. So hypervolemic hyponatremia. Or euvolemic means normal. That means SIADH can be a possibility. Polydipsia, which is primary, can be a possibility. If patient has hypothyroidism, that can also lead to hypovolemic hyponatremia. Okay, and excessive electrolyte free water infusion. Electrolyte free water infusion, if it is done also, it leads to euvolemic hyponatremia. Now coming back to hypovolemic hyponatremia. In hypovolemic hyponatremia, I told you it is a contraindication for use of Vaptons because the volume is already low. Why volume is low? Maybe patient is taking diuretics therapy because of the renal sodium loss like thiazides, or maybe patient is having adenocortical failure. That also leads to this thing, or maybe patient is having severe vomiting or severe diarrhea because of the gastrointestinal loss, or patient is having burns through the skin, the volume is lost. So these are the causes of hypovolemic hyponatremia. Now here, which of the following conditions can cause euvolemic hyponatremia? No, yes, no, no. So option 2 is correct answer because hypothyroidism can cause euvolemic hyponatremia according to our discussion. So these are the causes of hyponatremia. Very important. Like many of the times they are repeating questions here. Right? Now pleural fluid analysis. So if you're preparing for competitive exams, PG exams, MCQ based exams, the three liquids of the body, that is ascitic fluid analysis, pleural fluid analysis, and CSF. You can't go to exam without understanding the analysis part of these. Very, very, very important. When we talk about pleural fluid analysis, one important criteria is Light's criteria to be able to differentiate whether it is exudate or a transudate. Similarly, when we talk about ascitic fluid, there is serum ascitic albumin gradient. So based on that ascitic gradient, we decide what is to be done. Similarly, for CSF, the appearance part, how CSF appears, the volume, the pleocytosis. So the CSF is also per se analysis part is crucial in identifying the types of meningitis. So these are the three fluids that you should be very fluent before going to MCQ based exams. One or the other question will appear from general medicine point of view. Now if you see a report of pleural fluid analysis, See the pH, protein, total protein, LDH, and serum LDH. What is the most likely diagnosis? So, pleural fluid analysis, you should know about the Lights criteria. First, you should know about the Lights criteria. So, what is the Lights criteria? Lights criteria says if pleural fluid protein divided by serum protein, if it is more than 0.5, or pleural fluid LDH divided by serum LDH if it is more than 0.6, or if you don't want to take a ratio, if you just want to look at the upper normal limit for serum, so LDH levels, pleural fluid LDH levels, if you want to compare with the normal serum LDH value, if it is 2/3 the upper normal limit, then also you can do. So 2/3 upper normal limit. You don't have serum LDH values per se, but pleural fluid value in comparison to the normal value, if it is more than 2/3 the upper normal limit of serum. So if either of these are, at least one of the given criteria is correct, it is exudative pleural effusion. Now there are two steps in this particular question. You have to calculate the ratio. Now pleural fluid protein to serum total protein ratio is 0.5 by divided by 6.5, that is approximately equal to 0.08. That means it is less than 0.5. So this criteria is wrong. Or if pleural fluid LDH divided by serum LDH is 100 by 300, it is 0.33. It is also less than 0.6. So this is also wrong. So when these are not meeting, then this is transudative pleural effusion. Transudative pleural effusion. It's not exudative, it's transudative. So what are the causes of transudative pleural effusion? Now you need to have a table, like you need to differentiate between causes of exudative pleural effusion and transudative pleural effusion. Next step of the question, little complex, time taking one, but important, because in any MCQ based exam, you will see these kind of questions. Transudates, already told you, I'm only writing important points, not everything. In congestive cardiac failure, in nephrotic syndrome, in cirrhosis of liver, in all these conditions, you will see transudative effusions. Cirrhosis of the liver, you will see transudative effusion. Even in superior vena cava obstruction, and very importantly, mixed edema. In mixed edema, you will say transudative pleural effusion. Mixed edema is because of the hypothyroidism, whereas hypothyroidism causes euvolemic. In the previous slide, just go back to the previous slide, just to have an integration. Hypothyroidism causes euvolemic, not hypervolemic. Euvolemic hyponatremia, whereas the same mixed edema causes exudative pleural effusion. It causes exudative pleural effusion. Apart from that, one more cause is peritoneal dialysis. And now one more cause is urinothorax. Urine in the thorax, that is urinothorax. If you know this much, 7 causes, it's okay. Any other cause like neoplastia, metastasis, infectious diseases, pulmonary embolism, or any esophageal perforation, or SLE, or Meek syndrome, okay, they're all transudative. A lot of confusion around Meek syndrome, that's why I'm highlighting it. Say, if you're smart, you will learn these 7 for the sake of exudative. Anything out of this, you have to put as transudative. Transudative, mainly the what comes into my mind is any infectious cause or any neoplasia. It causes, sorry, there's a lot of confusion here. This is started writing transudative here, and here I'm writing exudative. Sorry, my bad. Now, any exudative cause, we have Meek syndrome, infection, and neoplasia. I'm so sorry. Right, let's move on to the let me read the question. I think what are the most likely diagnosis? Pancreatitis is exudative, mixed edema is transudative, sarcoidosis is exudative, rheumatoid arthritis is exudative. So correct answer for this particular question is mixed edema, because it is transudative pleural effusion. It is transudative Pleural effusion. Very easy, very important question. High yield question, right? Now, this is little tricky pathology question. Suddenly they have asked it, but interstitial lung disease we have discussed in detail. Interstitial lung diseases. Among the interstitial lung diseases, there is this one condition called cryptogenic organizing pneumonia. So, in this condition, what happens in any interstitial lung disease? It's a restrictive lung disorder, right? So, it's in a restrictive lung disorder, there is uh, issue with breathing. So, the patient will present with breathlessness. Spirometric findings will show restrictive pattern instead of obstructive pattern. And this cryptogenic organism pneumonia is previously known as bronchiolitis obliterans. It is known as bronchiolitis obliterans or cryptogenic organizing pneumonia. In this condition, histologically, you will see some loose organizing connective tissue here. It is a loosely organized connective tissue within the alveolar ducts. Okay, it is a polypoid plug. It is a polypoid plugs of loosely arranged connective tissue. So these are known as Masson bodies. Masson bodies, little difficult to kind of identify in a histopathological slide, but Masson bodies are characteristic of cryptogenic organizing pneumonia. So I think pathological bodies still relevant even in the modern era, because you'd see in like one or the two pathological bodies being asked in many entrance examinations. Now, what happens to respiratory function in case of old age? Very easy. Like first thing is, because they are old enough, recoil capacity of the lung is gone, so exercise capacity is low. Maximum oxygen uptake decreases, reserve capacity comes down, and because of the loss of recoil capacity, both FEV1 and FEV1 by FEC ratio are down. There is a ventilation perfusion mismatch that increases, and whenever there is hypoxia or hypercapnia, the ventilatory responses are reduced because of the autonomic loss. Impaired defense against infections because of the lack of protective agents in the mucin, and chest wall compliance is lost. Now, when you look at the question, consider the following statements regarding respiratory function in old age. There is increasing ventilation perfusion mismatch. Yes, agree. There is increased ventilatory response to hypoxia. Actually, it is decreased. They can't respond well. If there is hypoxia and hypercapnia, comparison to adults or children, they have reduced response. So this is wrong. There is decline in maximum oxygen capacity. Yes. There is decline in FUV and FCV. Yes. Okay, this is easy. So this one is wrong. So correct answer is 1, 3 and 4. 1, 3 and 4. Next question, which of the following statement is correct in respect to pulmonary involvement in rheumatoid disease? This year I had seen many questions about what kind of things happen, that is pulmonary involvement in case of connective tissue diseases. One question which we already discussed was hidebound chest, which is seen in systemic sclerosis. Now they are asking what happens in lung with regards to rheumatoid disease, rheumatoid arthritis. In rheumatoid arthritis, the most common pulmonary manifestation is most common pulmonary manifestation. What is the most common pulmonary manifestation? It is pulmonary fibrosis. Pulmonary fibrosis. So the patient will have restrictive pattern in spirometry. Pulmonary fibrosis, you will see. There is one more thing, that is if interstitial lung disease develops, the pattern is NSIP. Okay, most common pattern is NSIP. These are the two things that you need to know. Apart from that, in a case of rheumatoid disease, if there is a case of rheumatoid disease, chances of him getting lungs involved are 10 to 20%. So why this ratio is important? I had seen many value-based questions as well. Like if the 10 to 20% of cases Okay, they are associated with pulmonary involvement, and the mortality is 10 to 20% in these cases. If there is pulmonary involvement, it is the reason for death in 10 to 20% of the cases. That is the right way to put this value. Okay, and this condition is more common in men than women. That is, lung involvement with rheumatoid disease is more commonly seen in men. And the patients will present with pleural effusions. Patients will have pleural effusions as well. And these effusions are small, unilateral, okay, commonly, but they can also be large or bilateral. Okay, and they don't require treatment, they resolve spontaneously. Each line is important because questions, multiple completion questions, you need to know the topic as a whole, as if you're reading for a theory exam. Men are more common in men, pleural effusions are small, unilateral most of the times, and they resolve spontaneously. When you do biochemical testing in these cases, there is rheumatoid arthritis or rheumatoid disease pleural fluid finding. One characteristic finding I had seen questions coming hundreds of times, that is severely reduced glucose and raised LDH are the characteristic pleural fluid findings that you expect. Raised LDH and markedly or severely reduced glucose. Okay, and apart from this, I'm talking about pulmonary involvement. Yes, you will see 10 to 20% mortality. Most common pulmonary manifestation is pulmonary fibrosis. If it is interstitial lung disease, most common way is NSIP. And pleural effusions are more common in men. They are small and unilateral. They resolve spontaneously. If not resolving spontaneously, you can try oral prednisolone, but they do resolve spontaneously. Okay, and pleural fluid finding, markedly reduced glucose and elevated LDH are characteristic findings. Apart from these two, there is chances of rheumatoid nodules as well in these cases. In case of rheumatoid arthritis, in case of pulmonary involvement, you will see rheumatoid nodules which are developing in the lungs. Rheumatoid, I think pulmonary nodule is the right way to put. Rheumatoid pulmonary nodules are seen in these cases. And these are also incidental. There's no symptoms as such, they are incidental finding. Okay, they're multiple, they're asymptomatic, and very importantly, their location is subpleural. They're not inside, they're in the pleura. So, multiple rheumatic pulmonary nodules are seen as an incidental finding. Patient is asymptomatic and they're subpleural inside. Pneumoconiosis, that is an occupational lung disease, together is known as Kaplan syndrome. So pneumoconiosis plus rheumatoid nodules is known as Kaplan syndrome. Now let's read the options in this question. Rheumatoid pulmonary nodules are usually asymptomatic and detected incidentally on imaging. Rheumatoid pulmonary nodules are often solitary. No, they're multiple. Located near hilum. No, they're subpleural. So this is wrong. Pleural effusion in these patients is transitive and usually bilateral. No, pleural effusion is usually small and unilateral and it is exudative, as I told you. Rheumatoid disease or any connective disease, you'll see exudative pleural effusion. So this is wrong, this is wrong. Combination of pleural effusion and pneumoconiosis is no. Combination of rheumatoid nodule plus pneumoconiosis is known as Kaplan syndrome. Little confusing. So the correct answer here is option 1. Correct answer is option 1. Now, which of the following condition is a complication of bacterial pharyngitis involving extension of infection into internal jugular veins, leading to thrombosis and metastatic dispersal of the organism? See, one thing, it is little complex for me to understand. So what I'll do, I'll look at the options. One thing I'll know, cystic fibrosis is CFTR gene mutation. It is more concerned with mucus problem. Okay, thickened mucus, right? Thickened mucus. And this will lead to some atelectasis of the lung and also pancreatic problem, malabsorption. So this is straight away not an option. Now, Wegener's granulomatosis is a connective tissue disease. There is sinus problem, mucus problem, etc. Lungs are affected, etc. Right? So this is not an issue. Chronic pulmonary aspergillosis. It is fungal. Here, it is straight away a bacterial pharyngitis. So by elimination, I can say that it is Lemire syndrome. By only elimination, because even I didn't hear about this condition before, that is what is Lemery syndrome, but I have used the logic of excluding the options, okay, so that I can find one answer. You can try this if you don't know, but sometimes it might backfire, but at least you should have 90% of knowledge to kind of eliminate 10%. You can't go to an exam with 50-50 knowledge and hope for the best, right? Now coming back to the question, so the question is, which of the following condition is a complication of bacterial pharyngitis? So the bacteria which I am talking about here is an anaerobe. The name of the bacteria is Fusobacterium necrophorum. Okay, so this Fusobacterium necrophorum, which is an anaerobe, is actually leads to pulmonary abscess. Okay, pulmonary abscess, the causative agent for pulmonary abscess. So these pulmonary abscess are the cause of Lemery syndrome. What happens in these patients with sore throat, neck hemoptysis, dyspnea? So this problem, bacterial pharyngitis, due to this organism, it causes pulmonary the abscesses. Along with that, it also spreads to internal jugular veins, and it causes thrombosis and metastatic dispersal of the organism. So that is what is Lemery syndrome. Next question, a 42-year-old man with history of alcohol dependency presents with progressive abdominal distension. Abdominal examination reveals shifting dullness. Which of the following is the most appropriate to see? They're asking you the treatment of cirrhosis of liver. Now there is abdominal distension. The best way to remove abdominal distension is diuretics. So among the diuretics, the best option is always spironolactone. Any resistant fluid in the body, okay, the most appropriate drug is always spironolactone, right? So ascites, the treatment is diuretics, and spironolactone, which is given 100 to 400 mg per day, is the first line drug, because these aldosterone antagonists, they are powerful, but problem is they can cause, the side effect is painful gynecomastia. So if there is problem with this, we can go for amiloride, can be substituted in these cases. In severe resistant cases, we can even go for furosemide, but furosemide carries risk of hypokalemia. So the correct answer here is spironolactone. Now this question is about how do you diagnose stones in gallbladder. You might have if you're practicing as a physician, you will see a lot of this ultrasound abdomen reports. In most of the cases, there might be some incidental findings as well. It would be noted that multiple stones found in the gallbladder. Not all the gallstones which are present in the gallbladder are symptomatic. Okay, if they get into, if this is a gallbladder and if this is cystic duct, if this gets into it, if it blocks it, then you will start seeing cholecystitis condition, and if this goes and blocks the pancreas, there is chance of pancreatitis as well. Okay. Now, starting with investigation part, yes, the investigation of choice is always transabdominal ultrasound. There's no other option as such. I think pretty easy to answer this part of the question. Yes, there are other investigations that can be done as well. But with regards to transabdominal ultrasound, it is 85% sensitive and 99% specific. Okay, for renal stones, we can go for X-ray KUB, but investigation of choice is CT. Okay, non-contrast CT. So it is the best way. Even tiny stones can be identified here, but here 99% specific transabdominal ultrasound. CT, MRI, or MRCP, magnetic resonance cholangiopancreatography, or even endoscopic ultrasound, EUS, are also important, but they mainly help in identifying complications associated with gallstones. So what are the complications? It can be cholecystitis, it can be pancreatitis, right, etc., or gallbladder emphysema, bile duct stones. So for them, CT, MRCP, endoscopic ultrasound are more useful. Okay. Next question: which one of the following biologic agents are used in the treatment of inflammatory bowel disease? Okay. So its mechanism of action is Janus kinase inhibition. For management of inflammatory bowel disease, which can be Crohn's and ulcerative colitis, we have some biologic agents. Now the latest is biologics. So in the biologics, we have a category of anti-TNF antibodies, which can be used. Anti-TNF antibodies can be used, and under the category of anti-TNF antibodies, we have infliximab, adalimumab is one more drug. We have golimumab, and we have certolizumab. These are the 4 drugs which comes under the category of anti-TNF antibodies. Now there's one more class, that is anti-alpha 4 beta 7 integrin. Anti-alpha 4 beta 7 integrin. So under this category, we have this drug called vedolizumab. Very important, because they have asked this time about Janus kinase inhibitor, which is our next category, that is Janus kinase inhibitor. So the drug here in Janus kinase inhibitor category is our answer for this question, that is tofacitinib. Tofacitinib. Okay, I'm highlighting this. So here you have to focus. We have anti-TNF antibodies, we have anti-alpha B7 integrins, and Janus kinase inhibitors. Then one more category, that is anti-P40 antibodies. So under the category of anti-P40 antibodies, you have one more drug, that is ustekinumab. Okay, ustekinumab. A little difficult to pronounce, but these are all important. Any biologics, any drug which is in the category of antibodies, biologics, monoclonal antibodies, that is what I am referring to, is important for exam point of view. And this table contains the biologics which are used in treatment of inflammatory bowel disease. Very important. So the answer for our question is tofacitinib, which is a Janus kinase inhibitor used in the management of inflammatory bowel disease. Now, if you see an image, this is not spotted question, because image-based questions are never asked in the exam, but this is melanosis coli. Melanosis coli. This is interesting condition, because when we give laxatives, if there are addicts of laxatives, if they are given for long-term consumption, okay, when laxatives are given for long-term consumption, what happens? There will be accumulation of a pigment known as lipofuscin. So lipofuscin accumulation in the colon, okay, that too, to be more specific, they're getting accumulated in the lamina propria. Which layer of intestine? That is lamina propria of the intestine. Within the macrophages, you will see accumulation of the lipofuscin. Okay, lipofuscin. This will give this tiger skin appearance that you are seeing here. This tiger skin appearance is known as melanosis coli. Okay, so the answer is lipofuscin here. Melanosis coli is due to long-term consumption of stimulant laxatives. There is brownish discoloration of colonic mucosa like tiger skin appearance. It is because of accumulation of the lipofuscin. Okay, you tend to confuse melanosis coli means melanoma, not. It is because of lipofuscin, not to be confused. Right? Next question. Gilbert syndrome, Crigler-Najjar syndrome, Dubin-Johnson syndrome, Rota syndrome, they are all hyperbilirubinemias which are hereditary. So these hereditary hyperbilirubinemias can be classified into conjugated and unconjugated. Conjugated and conjugated, I remember as Dr. C, that is Dubin, Johnson, and Rotar. The remaining two, that is Gilbert and Crigler-Najjar, are unconjugated. So when I talk about Gilbert syndrome, look at the option 2, elevation of unconjugated bilirubin. So this is correct. Option 2 is correct for me. Now, what about this? What is the peculiarity of this syndrome called Gilbert syndrome? So, Gilbert syndrome usually you will see minimal elevation of bilirubin levels, somewhere around 3 milligram per deciliter or something. There will be jaundice. That's it. Nothing else will be there. Only jaundice. So the patient will not have any other things. That means no stigmata of chronic liver disease. Just jaundice, that to mild jaundice, unconjugated bilirubin. So right. Both option 2 and 3 are right. Now, in these cases, because there is isolated elevation of bilirubin, no chronic liver disease, usually there is no need to do biopsy at all in these cases. Hepatic histology is normal. Hepatic histology is normal in these cases. So, there's no need for it. Early liver biopsy is recommended. No. Option 4 is wrong. So, 2 and 3 are correct. Now, coming back to option 1. So, what is the genetics of Gilbert syndrome? Gilbert syndrome is inherited both in autosomal dominant and autosomal recessive fashion. Okay, it is the most common inherited disorder. So when I talk about hereditary hyperbilirubinemia, that is inherited hyperbilirubinemia, the most common cause is Gilbert syndrome. And this Gilbert syndrome, if it is autosomal recessive trait, means there is mutation in UGT1A1. So that too in the promoter region. So in the promoter region of UDP glucuronidase transferase enzyme, difficult to remember, just UGT1A1. This is autosomal recessive. But if there is missense mutation, which can be inherited as autosomal dominant. Now, what is the autosomal recessive trait of mutation in gene UDP glucal? Yes, this is also correct. So, the correct answer here is 1, 2, 3. Right? Done? So, let me do a correction here. The values are usually not nearly 3, it is nearly 6 mg per deciliter. Minor correction I want to do. Okay. Now let's move on to the next question. Single most important treatment and prognostic factor in case of alcohol related liver disease. Okay. I think the single most important treatment prognostic factor is ask them to stop alcohol. It's as simple as that. Very simple question to answer. And these are the lines taken from Davidson. Cessation of alcohol consumption is the single most important treatment and prognostic factor. And advice is lifelong abstinence is advised in these cases. Lifelong abstinence is advised. And general health and life expectancy are also improved when this occurs, irrespective of the stage of the disease. Right? So simple question, nothing much to discuss, but anything related to alcohol related liver disease is important from gastrointestinal system of UPSC CMS general medicine. Now there's a patient here, as you can see, there's no spotters are not given, but just for the clarity I'm giving you, there is this discoloration known as erythema ab ignae. See this erythema ab ignae. What is this erythema ab ignae? Patients with chronic pancreatitis, they'll have this chronic abdominal pain. What they do, they use this hot water bag for relief hot water bag. Because this is hot, it will cause in the long run erythema ab igne. Okay, so this skin pigmentation over the abdomen in a case of chronic pancreatitis to relieve chronic abdominal pain, he is using hot water again. That condition is known as erythema ab igne. Now, what are the other options? We have erythema infectiosum, our fifth disease. Okay, which will have slap cheek appearance rash, And next we have erythema marginatum, which we already discussed in the Jones criteria part of rheumatic fever. Okay, I told you, right? Peripheral red, central clearing, mostly on the extremities or trunk. Erythema nodosum is seen in multiple conditions. It is painful, tender, okay, redness in majorly shins of tibia, you will see here. Okay, I'll show you the image. So this is erythema nodosum that you see. This is slapper cheek appearance, which is erythema infectiosum, fifth disease. I think erythema marginatum, I already showed you the image along with the Jones criteria question. That is, there was a question on subcutaneous nodule, if you can remember, right? Chalo. Next question. Classic heat stroke. What is heat stroke? Heat stroke, there is core body temperature will exceed more than 105.1 degree Fahrenheit, or if you want to put it in centigrade, it is more than 40.6 degrees centigrade. If the body temperature is high, we call it as a heat stroke. Okay, so there is lack of thermal regulation in case of heat stroke, and the patient will present with dry skin. Patient will have pulse which is rapid and strong pulse will be there, and patient will also complain of dizziness. But most importantly, because of the lack of thermal regulation, the patient will not show sweating. So based on this question, I have seen many questions being asked in this topic of heat stroke. Sweating not seen in heat stroke. Now within heat stroke, there are two types of heat strokes that you need to know. Okay, what are the two types of heat stroke? Heat stroke can be a classical heat stroke, or it can be exertional heat stroke. That means if there is an adult, okay, if there is an adult or child or adult, okay, or if there is that means younger patient, or if there is an older patient. In older patients, we call it as classical heat stroke. These old cases will have predisposing health conditions, something which is not allowing them to regulate heat properly, or they are under some medications. So in these old people, they don't have to have exertional heat stroke. Okay, whereas young people are healthy, they don't have any predisposing condition. These older people are sedentary in classical heat stroke, but in exertional, these are active. That means they are exercising. At the time of exertion, they'll get this heat stroke. Right? So, because there is an exertion and exercising, you will see lactic acidosis, which is happening here, which is marked in case of exertional heat stroke. Whereas here, there is mild lactic acidosis. This is one area of differentiation between classical heat stroke versus exertional heat stroke. Apart from that, when you check potassium levels also, here you will see hypokalemia. Here you will see normal levels of potassium or normokalemia. Similarly, you will see hyponatremia. You will see normal sodium levels. So these are the classical differences between classic heat stroke versus exertional heat stroke. Coming back to this question, which of the following statements are typical for classic heat stroke? That means older patient, agree. Normokalemia, agree. Normal sodium, yes. Marked lactic, no. So 1 and 2 are correct answers here. Because hyponatremia and marked lactic acidosis are classical of exertional heat stroke, not classic heat stroke. Exertional heat stroke. Right? Got your point? Right. The correct answer is option 1 and 2. Now let's move on to the next question. Now, which of the following statements are correct regarding Weil's disease? Weil's disease, otherwise known as leptospirosis. Okay, Weil's disease or leptospirosis. So, what are the Weil's disease is caused by leptospirosis is caused by bacteria known as leptospira. So it is caused by bacteria known as leptospira, which is spira. That means a spiral shaped gram negative. It's not gram positive, gram negative bacteria. So it belongs to spirochetes. Okay, they're flexible, spiral shaped, gram negative bacteria. And this leptospirosis or Weil's disease is a zoonotic disease. It's a zoonotic. So it is caused by virus is absolutely wrong. Okay, and classically the patients with this problem, this leptospirosis, they will have liver and kidney dysfunction. That means they'll present with jaundice, and they'll present with acute kidney injury or renal dysfunction, and they'll also have hemorrhagic diathesis, that is hemorrhagic manifestations or bleeding manifestations. So acute injury can lead to oliguria in this disease, right? And how do you diagnose this case of Weil's disease or leptospirosis? There is a gold standard investigation known as MAT, microscopic agglutination test, which is investigation of choice. Okay, immediately within the first week of developing disease, the MAT will be positive in these cases. Okay, and the treatment for Weil's disease is we give ceftriaxone IV. Okay, actually treatment is oral doxycycline. That is the confusion here. Oral doxycycline is given for 1 week, or we can give IV penicillin also. Penicillin can also be tried in these cases, or even IV ceftriaxone can be tried. Ceftriaxone. These are the 3 options that we have. Because first one is entirely wrong, easy to rule out, I think you can go for 2, 3, 4. You don't have to worry much. So the correct answer is option 2, 3, and 4. Right? Chalo. Now I think there is so much of bias towards asking this question. Examiner is fond of asking this SOFA question. I think it has become a dictum that in NEET PG, INACT, for last 3-4 years, I have been observing that there is one question on SOFA, sequential organ assessment, or SOFA. SOFA scoring system or SOFA is important. It is sequential organ failure assessment. It is mainly used in acute pancreatitis, or even in any sort of emergency. This can be used. And SOFA, the parameters that we actually are the components of SOFA are, we check respiration with the help of ratio, that is partial pressure of oxygen and fractional pressure of oxygen. This ratio respiration can be measured. And in coagulation, we don't check for PT with INR, etc. We check for only platelet count. And for liver point of view, we check with the help of serum bilirubin. And from heart, we check for hypertension, that is BP, mean arterial pressure that we measure. And for CNS, we check Glasgow Coma Scale. And for kidney, we check mainly either creatinine or urine output. So this is SOFA. Now we have a new parameter known as quick SOFA, which is again examiner favorite question. Maybe next year they might ask you. So I have given you all the components of SOFA, that is respiration, coagulation, liver, hypertension, CNS, kidney. When you look at the options, this is correct, this is correct, this is correct, this is not correct, because we check platelet count, not PT with INR. So the correct answer is 1, 2, 3. Okay, this part is done. What is quick SOFA score? Quick SOFA criteria, we only check 3 things. 3 things. What is that? 1, yes, we check systolic blood pressure if it is less than 100 mmHg, less than or equal to 100 mmHg. Second parameter that we see is Glasgow Coma Scale, that is change in mental status. If it is less than 50, we'll give 1 score. And yes, we check for respiratory rate. For respiration, we check respiratory rate, which is more than or equal to 22 per minute. If these are present, if score is 3 or more than 2, chances of death in pancreatitis cases is 10%. Okay. So if there is score of 2, that means organ dysfunction. Quick SOFA scale and SOFA scoring system have been very important questions nowadays. Now, what are the components to establish the diagnosis of criteria? See, criteria for brain death. I see questions in almost 20 years in last 20 years. In all MCQ based exams, they'll ask a question on what is the criteria of brain death. Very important one. You need to know, because if you're practicing, if you're working in a casualty and there is a death and you need to declare the death, okay, whether it is a brain death or not. Brain death declaration is important because when a person is brain dead and if he has given consent for organ donation, he is the best one, like for organ donation, right? You can counsel the attendants, and if they're willing to go ahead with organ donation, we can do that. So, ideal criteria for diagnosing brain death is important, very important. So, in that, what is important is brain death. You will see brain stem reflexes are absent. This is the concept. That means absent brainstem reflexes is one thing. Okay, brainstem reflexes are absent. Not spinal reflexes. Spinal reflexes can be present in this, but brainstem reflexes are absent. So, what are the brainstem reflexes? That is pupils. That is corneal reflex. Pupils are fixed in these cases. Yes, and corneal reflexes are absent in these cases. Vestibulo-ocular reflexes are absent in these cases. All the cranial nerve distribution, there is no motor response and no gag reflex. But spinal reflex can be present. Based on this concept, I had seen many questions in the regular MCQ exams. Spinal reflexes are present. Right? Now let's look at this question. What are the components to establish? See, one criteria is brainstem reflexes should be absent. Apart from that, the patient is deeply comatose. He is unresponsive coma, irreversible coma, right? Right? Now, next, patient should not have hypothermia, because before diagnosing brainstem death, hypothermia should be excluded. Before diagnosing brainstem death or brain death, the person should not be under effect of sedative drugs, sedative or depressant drugs like hallucinations. He should not be under those effect. This should also be prevented. So hypothermia is not correct answer, because hypothermia should be excluded. Okay, if you want to diagnose the patient is deeply comatose, not under effect of any depressant drugs, hypothermia should be excluded. And also you have to check for serum electrolytes, blood glucose levels, and acid base imbalances, or metabolic or endocrine causes should be excluded, because they are reversible. Whereas brain death is irreversible, it is unresponsive coma, no problem with temperature, no problem with any of the metabolic panel. Then only you will diagnose it. Okay. Now the final criteria for diagnosis is there shouldn't be any respiratory movement when patient is disconnected from the ventilator. For that, the PSEO2 should be elevated to 6.7 kilopascals per 50 mmHg. This standard value. But the concept here is you are removing the ventilator pipe. So then there is elevation of CO2 in the body. In spite of elevated PCO2, the body should be in apneic state. The body shouldn't respond. So the correct answer here is 1, 2 and 4. Option 2. So quickly we have covered the criteria for brainstem death with the help of this question. Right? Now, the most common cause for non-traumatic subarachnoid hemorrhage, we all know, berry aneurysm or sacral aneurysm is the reason for subarachnoid hemorrhage. Subarachnoid hemorrhage question is important for MCQ exams because it comes with thunderclap headache. Or to be more precise, the woman will be describing this as worst headache in her life. Headache in her life. Okay. Now this subarachnoid hemorrhages, most of them, almost 85% of the subarachnoid hemorrhages are because of saccular or berry aneurysms. The cause, saccular or berry aneurysms, which occur at the bifurcation of the cerebral arteries. And the most common site is anterior communicating artery. That's almost 30% of them come from anterior communicating artery. Next is posterior communicating artery, 25% of them will start, and middle cerebral artery in the order of preference 20%. Maybe in the future they'll ask you sequential arrangement kind of questions in this here. The subarachnoid hemorrhage is mainly because of the saccular aneurysmal rupture. I have discussed this question in greater detail in the regular course. You need to know what is type 1, 2, 3 and 4 respiratory failure. This perioperative respiratory failure is type 3 respiratory failure. Okay, it is mainly because of atelectasis of lung. After the anesthetic effect, after general anesthesia, there is decrease in residual capacity of the lung. So lung dependent components are collapsed. So this atelectasis leads to perioperative respiratory failure, also known as type 3 respiratory failure. Next, the murmur of MR. Any mitral wall lesion is best heard near the murmur of MR is bed mitral irritation or mitral area is best heard at cardiac apex. Okay. Let's also discuss a little bit about the characteristics of the MR murmur. MR murmur is pansystolic, blowing in nature, heard better at cardiac apex, and it radiates to axilla, cardiac apex. Radiation is present, radiates to axilla. Apart from that, MR is characterized by soft S1, S3 is present, and left ventricular hypertrophy is present in these cases, which lead because of the volume overload. So these are the characteristics of MR, right? This is tricky question because this Birch-Wartowski score is not mentioned either in Harrison or Davidson. This score is used to assess, it is a scoring system to assess likelihood of thyroid storm. Whereas other scores I know. So far I already told you any acute condition, mainly acute pancreatitis. Expanded disability status scale or functional status scale are used for assessing multiple sclerosis. DAS28 score, very important, rheumatoid arthritis, previous year question. They have asked questions on this as well. DAS28 score is used to assess the disease activity of rheumatoid arthritis in 28 joints. Number is 28 joints. This is disease activity score in 28 joints is DAS28 score, mainly used in rheumatoid arthritis. Now look at the question. 28-year-old female, delirium, mainly fever plus delirium. She is taking anti-thyroid medication. You need to know that carbimazole is an anti-thyroid medication. Anti-thyroid medication, carbimazole. So carbimazole 40 milligram daily. She is on an anti-thyroid medication. Why people take anti-thyroid medication? Maybe she is having excess thyroid in the body, usually Graves' disease or hyperthyroidism. For that she is taking, but she missed her dosages for the last 2 days. That means she might end up in thyroid storm because of the withdrawal. Okay, so thyroid storm because antithyroidic medication is not taking. So to assess the severity of this disease, the best option is Birch-Wartowski score. Okay, the details of the score are little complex because it's a very big score. I'm not discussing that here. Even it is not covered in thing. So maybe with exclusion you can come to this option, that is Birch-Wartowski score. I think this is easiest question. One question was what is the mode of inheritance of Wilson's disease, that is autosomal recessive. The next question is which part of brain is affected in this. See, Wilson's disease patient is It is Wilson disease is hepatolenticular disease. Liver gets affected, the lenticular part of the basal ganglia gets affected. So basal ganglia is a primary organ. That's the reason in Wilson disease you will see movement disorders, because basal ganglia is important in maintaining the movements of the body properly. Patient will have movement. If there is deposition of the or if there is problem with basal ganglia, if there is copper deposition in the basal ganglia, that is visualized in the MRI, T2 flare MRI as panda. See this? So this panda sign in MRI is characteristic of Wilson disease. And this panda sign is seen near this basal ganglia. Right? One more question, maybe image based question or spotter based question that can be expected in radiology, which is not part of our syllabus. Maybe in other MCQ entrances, you might get a question on this panda sign, Wilson disease. But here, basal ganglia is the organ where you will see deposition of the copper in case of Wilson's disease. Next, which of the following are secondary iron overload conditions? See, iron overload is hemochromatosis. And this iron overload can be primary, that is hereditary hemochromatosis. It can also be secondary. That means there is excess iron in the body, which can be because of either chronic liver disease or iron loading anemias. Iron loading anemias. So what are iron loading anemias? There are a lot of infusions that happen with thalassemia major or sideroblastic anemia or chronic hemolytic anemias or transfusion or parenteral iron overload, dietary iron overload. These are all iron overload. Whereas chronic liver disease, that is hepatitis C, is associated with, this is confusion. Hepatitis C associated liver disease is associated with hemochromatosis condition. Right? Now let's look at the options. Which of the following are secondary? Transfusion, yes. Thalassemia, yes. Hepatitis C, yes. So the correct answer is 1, 2, and 3. Right? Now, next question is from neurology, that is Alzheimer's. Alzheimer's, we all know, loss of memory. Now, when I say loss of memory, is it recent versus remote? Is the question. See, both are lost. Both recent memory is gone, that is short term, or remote or long term. Both are gone. But more obviously evident are the recent ones. Obviously evident. That means you can elicit them. Long term stays most of the times. But both are affected. Both are affected. This is memory loss. Now, in Alzheimer's, the cortical functions are affected, including memory. The other cortical functions also are affected in this. The patient will have, apart from loss of memory, he will have apraxia, he will have aphasia, he will have anosognosia. If I keep telling you all these things, it would be like time consuming. We are already exceeding more than a couple of hours to discuss general medicine. I will just rush fast, but in the process, I'll not miss the important things. But at least you need to know that apart from loss of memory, you will also see apraxia, aphasia, anognosia in these. That is, cortical functions are getting affected. So I can say that it is a disorder of cerebral cortical function. Yes. Only short-term memory affected? No. Both short-term and long-term are affected. Patients deny that there is anything wrong. So that is anosognosia. This is right. Depression is commonly present in these patients. So 1, 3, and 4 are correct answers. So option 3 is correct answer in these cases. Right? Now, this is a new concept. Next question, G lymphatics. Have you seen any lymph node in the brain or any lymph duct in the brain? No, right? So brain, for long we used to think that the concept is that brain is immune privileged. Immune privileged because there is no lymph nodes or lymphatics as such. There's no classical lymphatic system. But recently, there were two systems that were identified. One is G lymphatic system, which is CNS, and there is one more system, that is lymphoid-like structures, which is not that important for exam point of view. But for now, what you need to remember is the details I have given in the answer, full answer, which is part of the course. But G lymphatics is the lymphatic-like structure is seen in CNS, central nervous system. Which among the following vectors transmits filaria lova? I think infectious diseases subject took me a lot of time because I was able to cover a lot of parasites, lot of bacteria, lot of viruses, because it's an elaborative topic. We can't skip, because 1 year if they ask lova, next year they'll ask something else. Okay, it's not that the questions are getting repeated. The topics and important bacteria, virus, and parasites are getting repeated. Coming back to the vector, okay, we have 4 vectors. Let's write down. Okay, let's write down the filaria which to transmit. The vector simulium transmits onchocerca, volvulus. These are all memory based. I can't help you with concepts here. Cyclops will transmit Dracunculus medinensis. Culex mosquito. Okay, culisoid, not culex, sorry. Culisoids transmits Manzanilla, and Chrysops transmits lova. So this lova is caused by filaria. So these are the filaria and these are the vectors. So vectors and simulium is onchocerca, Chrysops is lova, Cyclops is Dracunculus medinensis, and Culisoids is Manzanilla. So this is the correct answer. That is, sorry, Chrysops lova is the correct answer for this particular question. Which of the following is the most favorable prognostic parameter in Bell's palsy? See, when there is a case of Bell's palsy, the problem is the facial nerve is getting affected. That is, it is element type of palsy, that is lower motor nucleus. That is, in the facial canal, it is getting affected, it is swollen. Now, this nerve has 3 kinds of injuries. It can be neuropraxia, that means only half cut or incomplete palsy, or it can be oxonotomesis, that means complete cutting of the nerve. If complete cuts, it only degenerates. It is very difficult to regenerate. But if it is a partial cut, it can regenerate. That means any incomplete paralysis is a good sign. So incomplete paralysis in the first week is always a very good prognostic sign. But if there is axonotomesis, if there is cutting of the nerve, then denervation happens. So this denervation after 10 days, if you do, it takes time for nerve to degenerate, right? Because of the nerve cut. So this denervation potentials are detected by EMG only after 10 days. And if you see denervation in EMG after 10 days, it's a bad prognosis. So this is good prognosis. This is bad prognosis. So the right answer for this question is, which of the following is most favorable prognostic parameter? That is, incomplete paralysis in the first week is the most favorable parameter in case of Bell's palsy. Right? Now, which of the following group of drugs is ineffective against gram-positive bacteria? Now, we have 4 drugs here. Okay, starting with, we have monobactam. Monobactam, the classical drug is Astrionum. Astrionum is the classical drug which is available for monobactam. This is active against only gram-negative bacteria. It is inactive against anything. So the correct answer is monobactam because it is active against gram-negative. Coming back to other options. Glycopeptides, you need to know the answer. That is, vancomycin is the classical example, or teicoplanin. You know, vancomycin is active against gram-positive, mainly gram-positive organisms. Okay, mainly gram-positive organisms. So here question is ineffective against gram-positive. So astrionum is active only against gram-negative, ineffective against gram-positive. Ineffective against gram-positive. Right? 2 questions are done. Next, fluoroquinolones. These are broad spectrum, man. They act against this broad spectrum antibiotics acts against gram-positive, gram-negative, anaerobic, everything. Fluoroquinolones. Ciprofloxacin is a classical example. Ciprofloxacin. Now, first generation cephalosporins have excellent activity against gram-positive. Okay, they're also active against gram negative, but excellent against gram. So the correct answer here is monobacters. Which of the following statements is correct regarding leprosy? Okay, lepra reaction per se is very important for exam, for MCQ based exams. Lepra reactions are classified into type 1 and type 2 lepra reactions. Concept: type 1 and type 2 lepra reactions are commonly seen. Now, in type 1 lepra reaction, also known as reversal type, type 2 lepra reaction is also known as ENL type. So, type 1 leprosy reaction is called erythema nodosum leprosum. Wrong, because it is type 2. Right? So, the first option is wrong. Next, we'll move on to the discussion of type 1 and type 2 reversal. The mechanism of type 1. Okay, this is how I remember. You have to remember 5 number. Now this is 1 plus 4 is equal to 5. 2 plus 3 is equal to 5. That means type 1 lepra reaction is type 4 hypersensitivity. Type 2 lepra reaction is type 3 hypersensitivity, because at the end of the day you have to get this number 5. So here type 2 leprosy reaction is an immune complex mediated syndrome. That means immune complex is always type 3. So this option is right. So type 3 classical example is Arthus reaction. So 2 of the questions are correct. Now they'll ask a lot of questions on treatment in other MCQ exams. So the treatment of type 1 lepra reaction is corticosteroids, that is we give prednisolone. Okay, whereas thalidomide is the drug of choice in severe cases. Thalidomide for type 2 erythema nodosum leprosum. Thalidomide, even prednisolone can also be given, but thalidomide is the one question which constantly being asked in the exams. Right? Now, lion face appearance is seen in tuberculoid leprosy. Okay, the discussion is not going to end only if you know that type 1 and type 2 lepra reactions. You need to know what are the different types of leprosy presentations. Alright, so let's do a quick review of the type of leprosy presentations. So now first one is you have tuberculoid leprosy, and you have borderline leprosy, and you have lepromatous leprosy. You have lepromatous or LL. Borderline is BB or BL, whereas tuberculoid is TT or borderline TT. Okay. Now, the type of skin lesions which are expected in tuberculoid type. This is also very important for MCQ exam. This concept, any MCQ exam, it applies. Now you will see sharply defining annular lesions. Okay, sharply defined annular lesions. And these skin lesions also have nerves which get affected. So there is anesthesia. That is, when you touch, there is no sensation. Okay, and they have nerve abscesses, which is classically seen in borderline tuberculoid leprosy. The nerve abscesses are most commonly seen, and these annular lesions, asymmetric macules, they have central clearing, borders are raised. Now, borderline BB and BL, intermediate between borderline TB and LL type E, these are ill-defined plaques. So these are plaque kind of lesions. Okay, and these are again anesthetic, or they can be hyperesthetic or anesthetic lesions. Now next, lepromatous leprosy is important because these are multiple nodules kind of lesions. You'll see plaques, but nodules, and these nodules are more on the face, giving the appearance of leonine faces, lion-like face in lepromatous leprosy. Leonine faces, classical of lepromatous leprosy. Okay, and you will see hyperesthesia here. Okay, this much is enough. So this is coming back to the question. Lion faces appearance is seen in tuberculoid leprosy. No, I don't agree, because that is classical of lepromatous leprosy. Nose is the last site of involvement in lepromatous leprosy. No, Actually, actually, um, Mycobacteria leprae, it prefers cooler areas. Okay, face, ears, nose, nasal mucosa. Actually, nose is earliest site of involvement. Earliest site of involvement in leprosy. Right? So you need to know that. Mycobacterial leprae usually attracts cooler areas. So what are the areas which get affected? Skin is more commonly involved, like face, ears. Yes, nasal mucosa is more commonly involved. Peripheral nerves are affected, eyes, and even testes are affected. Testes are last or later. Okay, testes are later. Nasal mucosa is early. Now there is a 56-year-old gardener, thornprick, sporotrichosis. I think if I discuss this, I'll be wasting my time because like I had seen in my practice of teaching students like this 100 200 times I had discussed this question. Purulent discharge. It is sporotrichosis caused by Sporothrix shinkai. Okay, so let's move on to the next question. A 36-year-old man presents with decreased appetite, soreness in the mouth, diarrhea, irritable, bright red tongue, pigmented scaly rash around the neck, that is Cazel's necklace. I have seen in last 6 years, lot of MCQ based exams they are giving this Potter of Cazel's necklace. Okay, you will see in the neck there is uh, Cazel's necklace kind of dermatitic rash is there. So this indicates dermatitis. There is diarrhea. There is irritability. Maybe in the future the patient might have uh, dementia, which can lead to death. So all these, the 4Ds, are classical of niacin deficiency, and which leads to pellagra. And pellagra is commonly seen in people who eat corn or maize as a staple diet. Very complex question, right? It's like USMLE pattern question. There are multiple things that you need to know to be able to solve this kind of question. Okay, so it is a clinical scenario, niacin or vitamin B3 deficiency that you see here. Vitamin B3 deficiency is noted in these cases. Now, accrudated dermatitis, very easy. Zinc deficiency. It's a spotter question. The spotter is not given, just like. Now, next question is one of the lengthy question. Consider the following statements with regard to treatment of vitamin A deficiency. We all know fat soluble vitamins cannot be excreted through urine. They stay in the body. So any excess or hypervitaminosis is dangerous. So what are the fat soluble vitamins? A, D, E, K. They shouldn't be consumed in large quantities. Among them, uh, hypervitaminosis A is dangerous because it can cause liver damage and it is also teratogenic. That's why young reproductive women who are taking retinoids for acne or skin problems, they are advised not to conceive because it is teratogenic. If they prefer to conceive, they should at least stop 6 months before planning pregnancy. So repeated high doses of retinol can cause liver damage and teratogenicity. I will definitely agree with that. Any acute overdose of vitamin A leads to raised intracranial pressure. Yes, raised ICP is a common manifestation of hypervitaminosis A and skin discoloration. I'll agree with this. Regular vitamin A supplementation is recommended for pregnant women even in countries where vitamin A deficiency is not endemic. No, 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 no. It's not recommended at all because it has toxicity problem. So this is wrong. Excessive intake of carotene may cause harmless orange pigmentation. Yes, this is right. So the correct answer is 1, 2, and 4. So option 2 is the right option here in this case. Right? Yeah. So this harmless orange pigmentation is known as hypercarotenosis. Next question. Koebner phenomenon, very simple. Koebner phenomenon is actually seen in psoriasis. It is also seen in lichen planus. It is also seen in vitiligo. It is also seen in erythema multiforme. See, I used to work after my MBBS. I didn't join my PG MD directly. I took a break for an year. I joined into a dermat unit because I was interested in this cosmetology and cosmetology practice. There we used to do mesotherapy. for hair loss. Mesotherapy in the sense we used to use needles and we were to inject a minoxidil directly into the scalp. Okay, so when we used to prick them with the needle and inject the minoxidil directly into the scalp, there was one case of psoriasis. Okay, unknowingly, one of my colleague, I think it's not me, one of my colleague has done mesotherapy, and the lesions rapidly spread. The psoriatic lesion was there on the scalp on the one side, and we could see multiple lesions of psoriasis coming up. Then I realized the importance of Kobner phenomenon. Kobner phenomenon, whenever there is a sites of trauma, the lesions will appear. Isomorphic lesions, similar to the one lesion, will appear in the vicinity. So it is seen in psoriasis. Same thing. If there is an injury in vitiligo patient, you will see a new white patch. Lichen planus also, you will see a lichenification. Erythema multiforme also. These are the four conditions where you will see Kobner phenomenon. Behçet's disease, we have a classical test known as Pathergy test, which is also tested in this exam. We'll come back to that. So this is easy. Human hair growth cycle. We used to show these charts to the patients during consultation. Okay, we used to explain them that anagen is a growing phase, catagen is a transition phase, and telogen is the resting phase. Telogenic effluvium, do you remember after pregnancy there is sudden loss of all this telogen hair? So telogen is not a transitional phase, catagen is not a resting phase, anagen is, yes, a phase of hair growth. So answer of option 1 is the only correct answer according to this. Exogen is shedding phase. Now consider the following statements regarding oculocutaneous albinism. See, albinism versus vitiligo. Vitiligo is an autoimmune condition, not every time, but in vitiligo what happens? Okay, in vitiligo what happens? There is destruction of melanocytes, melanocyte destruction. Whereas albinism, there is only decreased melanin synthesis. If you know this concept, you can answer this question. Now, in oculocutaneous albinism, the disease results from genetic abnormalities leading to destruction. No, decreased synthesis of melanin. So option 1 is wrong. If option 1 is wrong, we are only left with 2, 3, 4, which are right statements. Yes, type 1 albinism is defect in tyrosine gene. Agree. Patients may present with other problems like oculocutaneous, eye, poor vision, nystagmus, strabismus. Yeah, that's why it is oculo. Skin means all the albinism glands are white spots that you see, and patients are increased risk of sunburn and developing skin cancer. I also agree with these two. So option 2, 3, 4 are the right statements here. Now 42-year-old man, recurrent oral ulcers, iridocyclitis, genital ulcers. What are we looking at? We are looking at a condition known as Behçet's disease, which is diagnosed with the help of Pathergy test. Simple. A lot of times this question has come in the exam. Okay. Which one of the following statement is correct in the diagnosis of Giardia? Giardia lambia is grand old man of intestine. Grand old man of intestine. Okay. This Giardia, the patient will have chronic diarrhea and malabsorption as well. And this has a peculiar property known as intermittent shedding. Intermittent shedding. That means if you collect stool sample on day 1, you might not see the diagnosis for cyst because of the intermittent shedding, you have to take multiple samples. So stool sample should be examined at 2 to 3 days interval. Okay. Now string test or entero test is a classical test wherein we'll pass a thread into the duodenum, we'll collect the fluid and we'll check for the Giardia lambia. We don't check for cyst. We check for trophozoites of Giardia lambia here. Trophozoites, not cysts. Okay, jejunal biopsy samples can show presence of larva. There's no larva in Giardia. Giardia has only 2 forms, cyst or trophozoite. There's no larva here. We'll check for trophozoites of Giardia lambia by doing jejunal biopsy samples. Cystic forms of Giardia lambia remains viable in water up to 1 week. No, up to 3 months. That's why it is a waterborne disease. So this is also wrong. So the correct answer is concept. If you know the concept of intermittent shedding, you can answer this question. Intermittent shedding. Okay, golden word. Shall we move on to the next question? Focus, we're coming close. We're going to finish the questions. So this test itself, you're asking someone to get up from the chair, go and come back after a 3 minutes turn. While doing all these things, you are assessing for the gait and balance. It's as simple as that. The name itself, get up and go, gait and balance. I think you can't ask for a simpler questions in CMS than this. If you can apply common sense, you can answer it. Treatment of choice in gout. Gout, usually we give NSAIDs. But problem is, most of these patients who suffer with gout are chronic alcoholics, old age patients. They have multiple comorbidities. When you have multiple comorbidities, NSAIDs can cause renal toxicity. There is an effect called triple whammy effect. Okay, I'm not discussing that effect here. That would be very complex. But again, you need to understand that it is easy to say that you can give naproxen or any NSAID, but NSAIDs carry side effects. For that reason, in acute gout, still the drug of choice or treatment of first choice is always oral colchicine. Okay, so go with this. Even if there is NSAID, go with this, because in both in Harrison and Davidson, the same point is mentioned. Maybe in your standard PG coaching, it might differ, but UPSC CMS being a standard textbook based exam, though there are some controversies, even though in my practice I stick to the new algorithms, but still for teaching of UPSC CMS, I'm not going beyond the textbooks, because answers and key is always based on textbook. At least here there is no controversy in CMS. Maybe in NEET PG, because they don't release key and all, there's always some 10 or 15 controversial questions and discussion. Let's not get into that headache. Let's not focus on things which are not in our control. Okay. Next, see here, this is triangle of safety. When we are doing intercostal chest drainage for pleural effusions and all, treatment of pneumothorax and all, this is the area. You have a pectoralis major, you have latissimus dorsi and fifth intercostal space. Here you have to insert, and when you are inserting, okay, make sure that the superior border or inferior border, you have to be careful. There are other, the question is 56-year-old male, acute onset SOB, pneumothorax, intercostal drain. Triangle of safety is the best option. Simple, as simple as that. There is nothing called Pettilis triangle, don't get confused. Triangle of auscultation, it is present on the back side of the chest. See here. Best place to hear lung sounds or breath sounds. Hazelback triangle, we all know, direct and indirect hernia. You'll know direct hernia comes from this Hazelback triangle, which is anteriorly present. Which one of the following is an antidote for rivaroxaban and apixaban? Antidotes for anticoagulation is important. If patient is taking warfarin, what is the antidote? Vitamin K. Vitamin K complex, prothrombin complex concentrate. If patient is taking heparin to reverse the effect of heparin, what is the antidote? Protamine sulfate. Everything is an MCQ here. Protamine sulfate. They might give maths the following next time. If patient is taking dabigatran, then what is the this thing? This is last year question. Idarusizumab, 2024 they asked. Now this year they asked. I think there is unfound love for examiner in UPSC CMS for asking these new anticoagulants, that to oral anticoagulants. There's so much of interest in modern exams. Dabigatran, idarucizumab, and next we have rivaroxaban and apixaban. We have andexanet alpha. So this is the question now this time. Andexanet alpha is the correct answer for this particular question. Now, which of the following are included in common causes of mediastinal masses in superior and anterior mediastinum? See, I'm not giving you the whole list here. In the regular course, I have added the causes of mediastinum. I have divided them into different segments. Now, when you take retrosternal goiter and thymic tumor, they are present both in superior and anterior mediastinum, but neurogenic tumors are actually classical of posterior mediastinum. So the correct answer here is 1 and 2. Which one of the following is used to reverse the anticoagulant effects of dabigatran? Okay, the same exam they asked this again, right? This is idarucizumab. Which one of the following is a contraindication of doing a wireless capsule endoscopy? Wireless capsule. See, you're sending something which has no wire. Okay, that means when patient swallows this capsule through the mouth, okay, when he swallows, it should come out of the GI tract. If there is any obstruction in the passage, then it leads to intestinal obstruction. So for that reason, small bowel strictures are actually a contraindication for doing wireless capsule endoscopy. We do this endoscopy to see celiac disease, gastrointestinal bleeding, small bowel Crohn's disease. So these are all indications. This is contraindication. So the remaining are all indications for wireless capsule endoscopy. Now this lesion, what we see is erythrasma, usually seen in folds, skin folds, and it is because of Corynebacterium minutism. And when we do examination, as you see here, erythrasma is a mild chronic localized super infection caused by Corynebacterium minutism. And when we do Wood's light examination, you will see coral pink fluorescence. So this can be a potential question in the future. Coral pink fluorescence. Next question, which one of the following is correctly matched regarding classification of portal hypertension according to the site of vascular obstruction? Okay, so portal hypertension is classified into pre-hepatic, it is classified into hepatic, and it is classified into post-hepatic causes. So when you see portal hypertension, it can be the obstruction of the portal venous system can occur before starting of the liver, within the liver, or after the liver. After the liver means ducts are getting affected, like Budd-Chiari syndrome, like inferior vena cava webs, or even heart might be restricting, that is restrictive cardiomyopathy or constrictive pericarditis, or very severe CCF which is not allowing the hepatic flow to come out. All these are post-hepatic. Pre-hepatic means within the portal vein before entering into the liver, that is portal vein thrombosis or splenic vein thrombosis, or in very massive splenomegaly cases, like we call it as Banty's disease also, you will see pre-hepatic thing. But hepatic is important. Within the hepatic, you have sinusoids. If it is pre-sinusoidal or sinusoidal or post-sinusoidal is important. Within the hepatic sinus or before it or after it. Pre-sinusoidal, we have infections like schistosomiasis, congenital hepatic fibrosis. Sinusoidal is more common, that is cirrhosis of the liver. Okay, cirrhosis of the liver mainly affects the sinusoids. Even alcohol hepatitis also mainly affect the sinusoid. Post-sinusoidal is veno-occlusive syndrome. Now, sinusoidal is veno-occlusive? No, it is post-sinusoidal. Pre-hepatic, pre-sinusoidal, okay, portal vein thrombosis, agree. Intrahepatic, no, intrahepatic sinusoidal is cirrhosis. So this is wrong because it's not given. Post-hepatic, post-sinusoidal, no. Hepatic pre-sinusoidal is schistosomia. So this is also wrong. So the correct answer is option 2. The little bit of confusion here is pre-hepatic is pre-sinusoidal because it is before the sinusoid. So they just confused with the terminology. But pre-hepatic would have been enough to ask in this particular question. Little confusion. Now, which one of the following is a secondary cause of headache? See, primary headache is migraine, tension type, trigeminal. Secondary headache is medication overdose because we are using medicines. That's why it is a secondary cause. 32-year-old man, jaundice, that is liver getting affected. Patient is having lenticular, okay, facial grimace, right? Which of the following is clinical clue to the diagnosis? Young patient, recurrent jaundice, that is chronic liver disease. Facial grimaces means extrapyramidal features, that is basal ganglia getting affected. Basal ganglia. I think there's so many Wilson disease questions, right? So the Wilson disease is characterized by ocular finding known as KF rings. KF rings are Kiesner-Friesen rings where there is copper deposition. Where is copper getting deposited? In the cornea. Which layer of the cornea is an important question in ophthalmology? That is Descemet's membrane of cornea. Descemet's membrane of cornea. You have to be very careful with that. What are the other options? Osler's nodes at fingertips are seen in infective endocarditis. Erythema nodosum on the skin already showed you. Adenoma sebaceum is seen in tuberous sclerosis. So this is adenoma sebaceum that you see here on the face. This is Osler's node and Janeway lesion. Osler's nodes and Janeway lesions are seen in palms. Osler's nodes are tender and seen on fingers. Mainly on palm, you will see Janeway lesions which are non-tender. Both these are cutaneous signs of infective endocarditis which comes under Duke's criteria. Not to be confused with Jones criteria of rheumatic fever. right? Spotters are important. At least you can remember them long if you have an image in the mind, right? I think we're coming close. We're completing most of the questions. Let's rush even faster. Which of the following joints are commonly affected? See, osteoarthritis affects many joints in the body. But what you need to remember is this one. This hand picture is very important. I had seen n number of questions coming from this. Okay. So what do you see? Distal interphalangeal joint, proximal interphalangeal joint, metacarpophalangeal joint, carpometacarpal joint, first carpometacarpal joint, wrist joint, right? So when you look at DIP, osteoarthritis and psoriasis are more common. When you look at PIP, that is proximal, SLE, psoriasis, rheumatoid is more common. When you talk about metacarpophalangeal joint, rheumatoid arthritis is more common. Rheumatoid arthritis will not involve the distal interphalangeal joints, whereas osteoarthritis mostly will not involve MCP. So both DIP and PIP are commonly seen in osteoarthritis. And one more area, thumb osteoarthritis, that is first carpometacarpal joint is also involved in osteoarthritis. 1, 2, 3. Right? Now, first metatar, what are the joints which are involved? Proximal interphalangeal joint, yes. First metacarpophalangeal joint, yes. Similarly, first metatarsophalangeal joint is also involved. Next, fifth and sixth cervical vertebrae, yes. Ankle joint, no. Ankle joint, mainly knee joint osteoarthritis and hip joint osteoarthritis and shoulder joint are more common. Shoulder joint dislocations are more common. Knee and hip osteoarthritis are more common. That's the reason you will see a lot of knee replacements and hip replacements, but very rarely you will see ankle joint replacement, right? So the correct answer is 1, 2, and 4. Okay, we're left with 11 more questions. Just stay with me. Keep concentrating. PYQs are very important. You will get 20 to 30 questions from this in 2026. And PYQs helps in ruling out other options as well. And we are trying to cover lot many concepts which are again essential. So just stay with me for 10 more minutes. We're going to finish. Which of the following are causes of reversible dementia? See, dementia causes list is extensive. Almost you will see 70 or 80 causes of dementia. Among them, thyroid can be corrected, vitamin B12 deficiency can be corrected, thiamine deficiency can be corrected. But logic is dementia with Lewy body, like Parkinson's disease or something else, it is actually degenerative disease. Degenerative, it is irreversible. So these are reversible, 1, 2, and 4. So simply with exclusion you can cover, but in the model answer solution PDF of course in the website you will find all the causes, and I have highlighted all the reversible causes with the help of bold letters. Okay, so causes of dementia are always important. Reversible dementia has been asked multiple times in the exam. Now, which of the following are clinical features of frontotemporal dementia? Little tricky, because at such a level of depth, you need to learn with topic dementia. See, one thing is clear: dementia topic is important. Now, when I talk about frontotemporal, that is frontal lobe functions and temporal lobe functions will get affected. Right? Now, the clinical presentation will have personality change, which is concerned with frontal lobe. Language disturbance, which is concerned with temporal lobe. So both frontotemporal dementia, you will see personality change and language change. Right? And yes, though memory is a cortical function, it is preserved in the early stages. I agree. Anticholinesterases are the drug of choice. See, when you compare frontotemporal dementia versus Alzheimer's, they all have dementia, but Alzheimer's, they respond well to anticholinesterases. Though symptoms are similar in frontotemporal dementia, it will not respond to anticholinesterases because in frontotemporal dementia, the cholinergic system is not affected. Cholinergic system is not affected. So based on that concept, they have framed this question. So 1, 2, 3 are correct. Option 1, 2, 3 are correct in this particular question. Now, which of the following is the myelinating cell of CNS? So we have Schwann cells and we have oligodendrocytes. So Schwann cells are ideal for peripheral nervous system, which myelinate. Oligodendrocytes are ideal for central nervous system. So don't get confused. Go with option 4. Go with option 4. And one more important differentiation is one cell will myelinate. If this is oligodendrocyte, it will myelinate many axons. Whereas here, one now is myelinated by many squam cells. Okay, this is the classical differentiation between both of this. So, oligodendrocytes are squam cells, major differentiation. So, this is PNS, this is CNS, myelination. Now, which of the following is a correct description of Mees lines? Mees lines, you see, are transverse white lines on the nails of the fingers and toes. So, this is fingernail abnormality, and these Mees lines, which are seen in chronic arsenic poisoning, they are also seen in thallium poisoning. Thallium poisoning also they are seen. Right? Next, fomepizole is an antidote used to treat poisoning. Fomepizole is used as an antidote for two poisonings. One is methanol and other is ethylene glycol. Methanol and ethylene glycol. Digoxin we use some digibind and all. Cocaine we have symptomatic. We don't have particular antidote as such. Okay, so answer is methanol and ethylene glycol. Also option 1 and 4. This fomepizole is a alcohol dehydrogenase inhibitor. So the lot of questions on antidotes. So one topic that you should be very perfect is antidotes from general medicine, that is poisoning part. Now this 4A test is a screening tool for delirium. Which of the following parameters are included in 480? 480 tool. So this is not a first of it, this is tool. Now 4A's are, one is alertness, second is attention, alertness, attention. Next is abbreviated mental test. Okay, so it's not apnea. Okay, fourth A is acute change or fluctuating course. Acute change or fluctuating course. So the total 480 tool, what are the parameters, how to interpret, I have included in the description part. For now, it is not apnea. So 1, 3, 4 are the correct options. So option 3 is a correct answer. 4A tool is used for screening tool for the detection of delirium. Which of the following combination of lab test results are indicative of heavy alcohol? Heavy alcohol consumption, I know, GGT is a parameter. Now we have a latest parameter, that is CDT. Okay, carbohydrate deficient transferrin. If GGT is more than 35, CDT is more than 20, then we are looking at heavy alcohol consumption. The sensitivity is very high for these tests. Okay, so option 4 is the correct answer. Which one of the following prevents gastrointestinal absorption of thallium? In thallium poisoning, for the treatment of thallium poisoning, we give Prussian blue as an antidote. It will prevent the absorption. Okay, one more thing is, as we already discussed, Mees lines, the transverse white lines which are seen. Now in thallium poisoning, Prussian blue, which is exchange material for potassium ferric cyanoserrate, it is given in divided doses. It will prevent the gastrointestinal absorption of thallium. Right? No. I think there's one more question which was missing here. There was one question which I'll write here. That is one question on belladonna poisoning. Belladonna poisoning, the antidote is atropine. Atropine is an antidote for belladonna poisoning. Prussian blue is an antidote for thallium poisoning. Okay, and fomepizole is an antidote for ethylene glycol and methanol poisoning. These are the 3 antidotes that has been asked in the exam. Now finally, when we talk about exam of general medicine in India, that to toxicology, there won't be any question without organophosphorus poisoning questions, right? So farmer accidental consumption of pesticide, urination and excessive salivation, that is cholinergic manifestation. That's the reason we give anticholinergic, that is atropine is given. You might have given a lot of vials of atropine in your casualty postings, right? So cholinergic manifestation, cholinergic toxidrome. So these toxidromes I have discussed in greater detail in the toxicology part of pediatrics and toxicology also. I did discuss them. Now last question, salicylate poisoning. See, the beauty of salicylate poisoning is you will see mixed acid base disturbances in salicylate poisoning. In the early stage, you will see increased alkalosis. You will see, that means low PCO2 you will see. Okay, so this is correct. There is respiratory alkalosis. Later stage of the poisoning, this will manifestation to high anion gap, metabolic acidosis. That means anion gap is high, that is almost 18 millimoles, and acidosis 7.25H. So the correct answer here is 1 and 3. Salicylate poisoning has mixed acid base disturbance. You will say respiratory alkalosis with high anion gap metabolic acidosis. That means low PCO2, low pH, and increased anion gap. So all these parameters are included in 1 and 3. So the correct answer is 1 and 3. So this will conclude our general medicine discussion. So overall in 2020-25, I have recorded separate videos for general medicine, peds, general surgery, PSM, and OBG. All these 5 solved paper discussions, I'm going to put them into a separate playlist so that whoever is appearing or preparing for upcoming UPSC CMS exams, they can go through these videos to have a fair idea. This is just crisper way of discussion. The same PYQs, major focus on topics, will be covered as part of course. Now in the course, I'm not doing only PYQs. In the course, I'll select one topic and I'll discuss in detail, and meanwhile while discussing, I'll tell that these are the PYQs which has been asked. So it is not retrospective. The course is prospective, but course also includes this retrospective PYQ discussion, and we are trying to cover almost PYQ questions starting from 2018 onwards till date. So it is most up-to-date course. If you wish to enroll into our course, just log into UPSC MEDICO website. There is UPSC CMS course available. The same details will be added in the description of this video, right? And if you need any assistance or guidance or mentorship for UPSC CMS exam, you can call me on this number, okay, 8978 I'll be answering your calls. I'll guide you properly. I'll help you with the course enrollment, and we also offer interview guidance. So it's a long process. CMS is not a simple exam. You have multiple papers, you need internship guidance, and you need guidance in choosing the right cadre, the right post, right? And you also need guidance to come back and do PG if you're interested, and for career advancement also. For all those things, I'm going to mentor you out. Okay, so all the best for upcoming exams. If you have any doubts or questions, you can drop it in the chat, the comment section, or you can reach out to me on this number personally.